Good afternoon, everyone. So
Good
this is
afternoon.
thank you, ma. This is the Concept Academy. Um, we'll be starting Renal today. Let's see where we will get to. I want you all to be very relaxed so that you'll be able to get the gist of everything that is going on in Renal. So throughout the class, please let us mute our mics unless a question is asked that requires you to answer. Other than that, let us just mute all our mics and be noting the important point. So we'll go through the embryology, the anatomy, the physiology, pathology, and pharmacology using first aid. All right. So this is the kidney embryology. Um, there are three important embryological structures that are related to the kidney that you want to introduce or you want to familiarize yourself with. The first one is the pronephros. Pronephros. So this will function around the third to fourth week of development. That's when it actually comes into play. Then it's going to degenerate. So if you look at, I want you to be looking at this diagram that they actually drew here. You can be correlating that to the arrangement we have here. So this is the pronephros. Around the time the baby is born. So this is not supposed to even be there at all again. All right. So I'm trying to imagine how these pronephros can be tested. So maybe they can give a particular patient or a particular pregnancy, maybe in a particular animal, and they just mention maybe around the week 4 of development. Maybe it's similar to the development of the kidney in that animal is similar to that of human. So they may just say that maybe there is abortion around week 4 or week 3 or something. If at all, which of the following kidney is likely to be the functional kidney at this time? So you'll be thinking towards something like pronephros. Then we come to the next one, mesonephros. So around the week 4 of development, that's when it's going to come into play, when this pronephros is starting to degenerate. All right. Sorry. Sorry for the distraction. All right. So that's when this mesonephros is coming into play. Then around the first trimester. So if at all the question is related to the functional kidney, you will be thinking more towards something like the mesonephros. All right. The important point I want you to pick about the mesonephros is that it's also important in the male genital system. So it's also very male genital system development. So it's also very important there. So you can look at it and divide it into two parts, the upper part and the lower part. So anyhow you want to look at it. So the lower part being something you can easily relate to the kidney, the upper part, the upper part being something you can easily relate to the kidney, the lower part being something you can relate to the genitalia, genital system, something like that. I just hope I divided it very well. All right, that's just the basic thing. So you are not really expecting much to be tested on these pronephros, mesonephros. Really nothing much. So this mesonephros, when we get to reproductive system, we'll be unraveling it more. So we'll look at all these structures that are listed here and many more. Any abnormality that can happen to it, we'll all look at it. So you are not really expecting much about this mesonephros. So where your assignment begins for USMLE is at this metanephros. You can't go into the exam and not know everything that is supposed to be noted about the metanephros. And this is friend, Ureteropelvic, what do we call it? Ureteric board. So please never forget this guy. So metanephros, we'll look at it as, as a whole, ureteric board, and this is friends, ureteric board and metanephric mesenchyme. So these are the two guys we'll look at under this metanephros. So this metanephros is the basic thing points that you want to note under these three guys. The metanephros is the permanent kidney and is the one you are expecting them to ask most of the questions from. All right, so now let's start diving into the metanephros. So it's going to first appear around the 5th week. So you can look at this guy as pronephros around the 3rd week, mesonephros around the 4th week, metanephros around the 5th week. If that makes sense to you, you can note that. All right, then the nephrogenesis, the proper development of everything that's related to the kidney or renal development, so it's normally completed by the week 36 of gestation. So you can actually think around this area in the sense that they give a question where a child is delivered at maybe 30 weeks, and this is a question that's related to the kidney, and the question might just be asking about maybe the kidney is already well developed or it's not really well developed. So you expect the complete development of the kidney around the week 36. Now these two guys under this metanephros that you want to really note under 8, you need to pay attention here very well. So we have what we call the metanephric mesenchyme. Another name for it is metanephric blastema. Then the ureteric board. Another name for this is metanephric difarticulum. So in the exam, you don't want to be mixing them up because this is a difarticulum. It's more or less like something budding off. You can look at it like that if you wish. So whereas this is metanephric mesenchyme, so more or less like a blastema. So just like a mass, you can look at it like that if you wish. All right. So what you want to note about the ureteric board for the exam is what are the structures that develop from heat. What are the structures that develop from heat? So you want to note this. Then for the metanephric mesenchyme too, what are the structures that develop from heat? For you to know the structures that develop from heat, so we are going to draw a very simple diagram. So this is the Bowman capsule. Then this is the proximal convoluted tubule. So this is the distal convoluted tubule. To the collecting dot. Then from the collecting dot, you can link it up. Sorry, 1 minute, please. All right, so sorry for that. I'm coming. This one is supposed to get to distal so that you will get the gist of the color. Then collecting dots downward to the other structures. Okay, now you see this is a diagram, simple diagram that must be at the back of your mind. So from this, the end of the distal convoluted tubule here, you just draw a line and divide it. You see all the structures that you can see here, including the glomerulus that you have here, including the glomerulus, up to this distal convoluted tubule, they come from metanephric mesenchyme. While from the collecting duct or the collecting tubule down to the ureter, they all come from the ureteric bud. So, and this is the question you are expecting them to test you on in the exam. So they can draw a nephron like this and just put an arrow on any part here. If they like, they can put it around the proximal convoluted tubule and just say, where does it develop from? You just say metanephric mesenchyme. They may put an arrow here for the collecting tubule and ask you where is it or where does it develop from. Your answer is ureteric bud. And for all you care, that might just be the simple question they will ask here. So please don't forget the structures, proximal convoluted tube. Just sketch it on the paper they will give you if you are going to be confused. Draw a line here. That's going to really help you. Okay, so that's another important point. For these two guys to develop very well, they must interact. So two of them must interact. So the mesenchyme, metanephric mesenchyme, and the ureteric bud, two of them, they interact with themselves. So metanephric mesenchyme will induce ureteric bud to develop. Ureteric bud also will also induce the metanephric mesenchyme to also develop better. So can you see that interaction? It must really be well taken care of. I mean, you must note it. So if I thought there is an abnormal interaction between these two guys, it's either the kidney is not really that developed, or you have a lot of connective tissues that fill up the kidney. It's either the kidney is not developed, or you have a lot of connective tissue. I want you to be marking my words. I am choosing them carefully. So it's either the kidney is not developed, or you have a lot of connective tissue within the kidney. So just from abnormal interaction here. And that's actually the summary of what they want you to note for the exam here. So the last point I will just drop on that is that the ureteric bud is expected to be fully canalized by the week 10 of development. I put something here, get the gist about the ureteric bud and metanephric blastema or mesenchyme, because in all UK, that is what you are likely to be tested on. Then you come down to this area, ureteropelvic junction. Ureteropelvic junction. This is the last part to canalize. So you must never forget this area. This is the last part of the kidney to canalize. So if I thought there is anything that make the baby to be developed before time, so there may be this place might not have been canalized, so the baby may have congenital obstruction. So you want to note this is the last to canalize. All right, if at all it's affected, it can be unilateral or bilateral, and the most common pathology cause is actually the most common pathology cause of what you call hydronephrosis. So what do we mean by ureteropelvic junction? Ureteropelvic junction. So this is sorry, I will still be showing you the way I love to show you in the pictures, instead of me just drawing them. So I will just show you so that you have an idea of the way they are. Permit me, please don't be annoyed. So ureteropelvic junction, it's better for you to see it there. But can you see this? Can you see my screen?
Yes.
Okay, you are seeing all that, yeah, because I don't want to click on something that will now disrupt everything again. So I don't understand what this means. Oh. Okay, so this is the ureteropelvic junction. So this is the pelvic. So this is more or less like the ureter. The junction where two of them meet, that's ureteropelvic junction. If you look at this place, it's a bit narrow. So that is ureteropelvic junction obstruction. Do you get me? So just for you to have an idea of, okay, this is what they are trying to say here. Just be tagging along with all those information as I'm dropping them for you. Small. Okay, so that is the last to develop there. Okay, so if I thought there is this obstruction, if I thought there is obstruction here now, so it means that kidney will continue to produce urine. Once it gets here, it won't really be able to go down. You now start having what you call hydropelvis. Hydropelvis means that there is this accumulation of urine in the pelvis and it's now becoming dilated. So hydropelvis, then from there, all those nephrons and in fact calyces will start dilating. That's the next structure that is aborting the pelvis. So hydrocalyces. Then from there to nephron, you call that hydronephrosis. So hydronephrosis is not actually dilation of the ureter. Hydronephrosis is actually the dilation of the nephrons. When what do you have? When the filtrate accumulates in them. So when urine accumulates in the, let us assume that something is making urine to accumulate in the ureter, you call that hydroureter. So I just want you to get the difference there. But subsequently, when we start talking about hydronephrosis, we may equate them, everything, to hydronephrosis as a general term. So that's where this one is coming from, just for you to note it. So I want to show you one or two questions here, just for you to have an idea of how this can be tested. So I just want you to be noting those questions down and how they are presenting. Researchers working at the National Foundation for Prematurity and Birth Defect are investigating the physiologic processes that occur during embryonic kidney development. Now say their research focuses on the inductive signal exchange between the metanephric diverticulum and metanephric blastema that drive their differentiation into tissues forming the mature kidney. The researchers develop a method to reproduce the inductive signal that normally comes from the metanephric diverticulum. After applying this inductive signal to the metanephric blastema, which of the following adult derivative will most likely develop? So what are the structures you expect to develop from the metanephric blastema? So let us list all the potential answers from what we've done now. What are the potential answers that you think can be in this question? Glomerulus. Proximal convoluted tubule, loop of Henle. Yeah, distal convoluted tubule. So any of the answers you see there, any of these guys can be any of the answers. So out of all what you've listed, it's only the distal convoluted tubule that you are seeing here. I want you to try this for me, please. Okay, let us see if you can make a guess here. A 2-year-old boy is brought to the physician because of decreased appetite and abdominal pain for the last several weeks. Physical examination shows a palpable left-sided abdominal mass that does not cross the midline. A CT scan of the abdomen shows a large necrotic tumor on the left kidney. Histology examination of the kidney mass show primitive blastema cells and immature tubules and glomerulus. This tissue is most likely derived from the same embryological structure as which of the following? So which other structure do you think developed from the same embryological structure as these primitive blastema cells? So now we have endoderm, we have the mesoderm, we have the ectoderm. Where do you think these blastema cells is coming from? Let me mention the cells anyway instead of the layers. We have what we call mesenchymal cells, right? This blastema is the same thing as metanephric mesenchymes. True or false?
True.
So if that is the case, is there any structure here you think is coming from mesenchymal cells?
I think adrenal medulla.
Yeah, adrenal medulla. I was thinking papillary.
Why will you make that gross mistake?
Is it not muscle?
No, papillary muscles.
Papillary
muscles.
muscle. Exactly. Muscles.
see.
Exactly. So muscle. So now, which mistake did you make under the adrenal medulla? Which structure helps in the development of adrenal medulla?
Neural crest.
Exactly, neural crest cell. So I don't expect you to make that kind of unforgivable mistake. All right. So the answer here should be something like D until proven otherwise. All right. So papillary muscles are derived from mesoderm. The mesoderm is the embryonic progenitor of all muscle. So that's that. So I want you to look at this. Horseshoe kidney. Let us see that picture if I thought it makes sense. So I want you to look at this picture. Can you see this horseshoe kidney? Can you see it?
Yes.
Lovely.
Yes, sir.
Lovely.
Yes.
Okay, so I want you to look at this question now and try to launch an answer to it. A 30-year-old woman comes to the clinic due to recurrent urinary tract infection. She also has a history of nephrolithasis. Vital signs are normal. Examination is unremarkable. CT scan of the abdomen is shown. Fission of which of the following embryologic structures most likely explain this patient's CT finding? So what's the answer?
Metanephros.
So why don't you pick pronephros?
No, those ones they degenerate now.
Those ones
Function.
what's weak?
Someone say, Festus, why will you be thinking, if you are in your right senses, why will you be thinking towards pronephros? All right. So I agree with you. It should be more of metanephros. Why? This is a 30-year-old woman. He's already old. So whichever kidney that this patient is going to have, is going to be a permanent kidney. That's number one. Then that structure you can see is a fully formed kidney, but they are fused. All right, so that should be metanephros. So I want you to look at this and try to provide your answer to it. A 54-year-old woman comes to the physician for a follow-up examination after presenting with elevated blood pressure on both arms at a routine visit 1 month ago. Sorry. Okay. He feels well and takes no medications. He is 178 centimeter tall and weighs 99 kg. BMI is 31. Pulse is 76. Blood pressure is 148/85 on the right arm, 152/87 on the left. Physical examination and the laboratory study show no abnormalities. The physician recommend a lifestyle modification in combination with treatment with hydrochlorothiazide. Which category of patients do you first of all start or begin with hydrochlorothiazide as their
The
first
work
line?
is essential.
Hypertension.
Is it everybody with hypertension? The blacks. The blacks.
Blacks.
Yeah. All right. So mostly the blacks, they are the one that their first line is just this thiazide. All right. Mostly. So from which of the following embryologic tissue does the site of action of this drug arise? So where do you think hydrochlorothiazide acts on the nephron?
Distal
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 convoluted tubule.
So if it's distal convoluted tubule, where do you think it comes from?
Metanephric
Blastema.
So we go for B. Let's see the answer. So that makes sense. Let us see what you pick here. An investigator is studying the effect of antihypertensive drug during pregnancy. Follow-up studies show that the drug can adversely affect differentiation of the ureteric board into its direct derivative in fetuses exposed during the first trimester. Which of the following structures is most likely to develop incorrectly in the affected fetus? So now, what are the structures you expect to develop from ureteric board? Let's list them.
Collecting dots. The pelvic.
Pelvis,
Calyces.
calyces, ureter. Okay, so what's your answer now?
Collecting
Collecting dots.
dots.
Yeah, so we pick collecting dots. All right, and that's very correct. So that's that about this area. So all I want you to do is just to rehearse around this and you'll be fine. All these Wolvian and the wolf and the chimpancing dots, don't worry. We'll do them in what do we call it? Reproductive system. Okay, so we are done with that. Let's look at the Porter sequence. For the Porter sequence, the question is most likely to revolve around what you call oligohydramnios. So that is what the question is going to revolve around. So what that means is that when you read that question and you are saying something like this patient has the pregnant woman has oligohydramnios, one of the likely complication from that oligohydramnios is Porter sequence. Like, you just want to note it and watch out for it. All right. So now, why do they call it a sequence? A sequence because a sequence is a predictable series of anatomically related anomalies that develop as a consequence of a known primary disturbance. So cause and effect relationship. This patient is having oligohydramnios. You can predict what the baby is going to come down with. So that is why it's a sequence. So with oligohydramnios, there can be compression of the developing fetus. So why? Enough amniotic fluid is not produced. If it's not produced, the amniotic membrane will not be properly distended the way it should. So all this baby swimming the way it wants is not going to occur. So the membrane is likely going to be in close, is most likely going to be closely adherent to the baby's part, to the fetus part. So as a result, the fetus or the baby can come down with limb deformities and facial anomalies. All right, so that's that. It can even compress on the chest. So, and it can also, the lack of amniotic fluid again can also cause some respiratory abnormality. Why? The baby needs to swallow the amniotic fluid for proper lung development. So branching and the likes of all those airway. So because the baby enough amniotic fluid is not even present, so enough swallowing is not really going to occur. So the baby is going to come down with abnormal development of the respiratory pathway. So cause pulmonary hypoplasia. So which can also cause death in them. So oligohydramnios, can you see from limb deformity? You can see also respiratory problem and the likes. These are all predictable. So a baby that is born by a mother that had oligohydramnios, you can predict what the baby can actually come down with. Now, what are the causes of these oligohydramnios? Number one is this chronic placenta insufficiency. It's not, you don't really need to bother yourself much about it here now. So because you are still going to do it later. Reduce renal output. Now this is where you start becoming, you start paying attention to the causes for the renal. Reduce renal output. How come this baby can have reduced renal output? Maybe the baby has this autosomal recessive polycystic kidney disease. Now, I want you to look at this word. It's autosomal recessive. It is not autosomal dominant. So this one is autosomal recessive. You usually see it manifesting early in life. That's when they start manifesting showing some features. So autosomal recessive polycystic kidney disease. So never forget this. It's recessive. It's recessive, not the dominant. If they put dominant there, don't pick it. That will be wrong. Then obstructive uropathy. Any obstruction that you can think about or you can see. So the urine is being produced, but it's not really coming out. So you can think about the UPJ. You can think about the posterior urethral valve. So if it's posterior urethral valve, you will be seeing bilateral manifestation, because this is the, let me show you posterior urethral valve so that you have an idea of what is going on. So if you can look at this picture here, probably you can use it like this. So there is an obstruction down here. You can see bilateral dilation of the ureter. So that's just one thing about it that can cause because this one definitely is going to cause the what do you call it? The oligohydramnios, because no urine is going to come out, because that amniotic fluid is basically produced by the more of baby's urine. So they produce them. So if there is obstruction down here, then the mother will be having oligohydramnios in the pregnancy, and the baby will start having back pressure. Can you see all this stuff? So posterior urethral valve is the one they put there. So what about the ureteropelvic junction obstruction that I mentioned? That one is only going to manifest if it is bilateral. So if it's unilateral, the second kidney will take over. So, but for you to see oligohydramnios, then it must involve the two. So that's why in this test, they are only putting one. So I want you to note it very well with passion. Then bilateral renal agenesis. It must also be bilateral, because these are the points you are noting. Because if it's just only one kidney that is not formed, then the other kidney that is formed will do the function of the two. So, but if two of them are not formed the way they should, then the mother is going to experience oligohydramnios and the likes. All right, so that's that. And these are the conditions you can associate with Porter sequence. Pulmonary hypoplasia, oligohydramnios, the trigger, twisted face, twisted skin, extremity defect, renal failure. All right, so that's that. Let me show you one or two questions here, just for you to see the way they test this area. A 3 kg male newborn newborn delivered at 38 weeks gestation, develops respiratory distress shortly after birth. Physical examination shows low set hair, retrognathia, a flattened face, club feet. I want you to note this club feet very well. It's one of the clincher. Within a few hours, the newborn dies. Examination of the liver at autopsy show periportal fibrosis. So periportal fibrosis is one of the manifestations that you are also going to see in a patient that have ARPKD. All right, so they can have a lot of fibrosis. So the ones they are saying here is periportal, and dilatation of the peripheral intrahepatic duct. This patient condition is most likely associated with which of the following? So definitely this baby is having something you can associate with Porter sequence. So, and one of the things you can, why are you thinking towards Porter sequence? Here, you can see something related to retrognathia, flattened face because of that membrane that is quite adherent to the face of the baby, then club feet. So the baby could not even, everything is crowded within the mother's tummy because of that oligohydramnios. And to now give you the clincher to the cause, they are telling you that there is on liver autopsy, they are seeing periportal fibrosis. Start thinking towards ARPKD. All right, if it's ARPKD you are thinking about, I want you to look at the word just to give you a glimpse. This is recessive, autosomal recessive. So there is a particular part of the kidney that sounds recessive, and that is collecting. I receive, I collect. So one thing about the autosomal recessive PKD is that most of the cystic dilatation you see in them, they usually occur more, or most of them you see them in the collecting dot. So by that way of remembering, you will not mix it up. So when I get to polycystic kidney disease, I will also mention it. So don't be distressed, just to show you how this is related to Porter sequence. So the answer here is going to be cystic dilation of the collecting dots. I want you to look at this question here. A 1-hour-old boy in the neonatal intensive care unit due to tachypnea and hypoxia. The infant was born at 39-week gestation via cesarean delivery due to recurrent variable deceleration. All these stuff, we do them in step 2. But once you start seeing all this deceleration, they are not really good sign. The pregnancy was complicated by lack of prenatal care. The infant weight is 3.2. Physical examination shows a flattened face, bilateral club feet. The same picture. All right. Breath sound are markedly diminished bilaterally because a nerve branching did not occur. We will do it in respiratory system. The infant is intubated and mechanically ventilated, but oxygen level do not improve. So despite giving the patient oxygen, he dies an hour later. Which of the following is most likely to be found during autopsy of this patient? So what do you think is likely to be found? Anybody?
Renal
Genesis.
You think towards renal genesis because that's the only cause in this question that you can factor in this question you can associate with oligohydramnios. There is no any other thing here that is related to oligohydramnios. So that's why you go for option C. In fact, if you want to be very specific, what kind of renal genesis, unilateral or bilateral?
Bilateral.
In case in the exam they go and put unilateral and bilateral there, you know that it's bilateral. I want you to pick your answer here for me, please.
Dr. Festus.
Yes.
The one we did before this one in the valvular obstruction of urine outflow. Can someone just think that it's urethral?
Yes, that's very posterior urethral valve. That's what they are talking about. But that will not be the answer here because I already mentioned some attributes that you can associate with ARPKD. They are in the question. Do you get me? So that's that. Even though this is a very confusing question, if you are not very careful, because this is a male, maybe like it's posterior urethral valve. But all these other features they are putting here, they do not. You don't see them in posterior urethral valve. So you see them in the ARPKD.
And all that. Okay.
All right. So I want you all to try this for me, please. A 24-year-old woman comes to the office for a routine prenatal ultrasound examination. She is 19 weeks pregnant based on her last menstrual period. This is the patient's third pregnancy, and there have been no complications. Family medical history is unremarkable, and both of the patient's children are healthy. The examination reveals a male fetus with bilateral enlarged kidney with diffuse small cyst. The amniotic fluid volume is very low. No other anomalies are seen. Which of the following will most likely be present in this newborn? So what do you think you are likely going to see in this patient newborn?
Pulmonary
Pulmonary
hyperplasia.
Pulmonary
hyperplasia.
hypoplasia. So let me assume that it's the same thing. So what do you think is the answer here?
Sequence.
So it's just
Sequence.
sequence they are just trying to test there. So you can read it when you are listening here. All right, so that's all about the sequence. So when they give it, you already have an idea of what they will test in the exam. So now come down to the horseshoe kidney. I know you've all heard about horseshoe kidney. I showed you a diagram of horseshoe kidney. Now, what you're asking yourself is that what are those things USMLE will ask you about horseshoe kidney? That's all you need, not for you to become horseshoe kidney specialist. So this is the same diagram they are likely going to give in the exam. You can see for those that have seen Hush in Lisha B movie, I know that's what many people have been watching nowadays. They don't read USMLE again. All right. So the if you look at, if you can check for how it relates to the this picture, how it relates to the horseshoe, so they look alike. Do you get it? So this is how the diagram will be given. You will just see the inferior pole. So this is one kidney, this is another kidney, and the inferior pole is fused. That's all you need. You just see them fused like this. You just make your diagnosis of horseshoe kidney. So that's that. So inferior pole of both kidney fuse abnormally. They are not supposed to fuse. So that's your question number one. In case they ask you that, okay, where do you think the abnormality is coming from? It's just the abnormal fusion of the inferior pole. That's all. Abnormal fusion of the inferior pole. Okay, now, because they are fused, the two of them want to ascend. As they are trying to ascend, there is a particular vessel that is going to cause their arrest. There is a particular vessel that is going to cause the arrest of that ascent. So when they ask you that kind of question, that what's the name of the vessel, the answer is inferior mesenteric artery. This is your next question. The vessel that is causing the two kidney not to be able to ascend, because most of the horseshoe kidney you still see them down there. So the reason why you still see them down, at the lower part of the abdomen, is because this vessel does not allow them to complete their ascent. So as a result of that, they just stayed down at the lower part of the abdomen. So the name of the vessel is very important. If you were to be the lecturer or the person that will set the question, this is one of the questions that you don't want to ignore, to ask, to test. Which vessel is that? And that is inferior mesenteric artery. So by one reason or the other, let us assume that the ascent just shall manage to go up a bit and now compress on this inferior mesenteric artery. So you can imagine how the patient is also likely going to present. Or let us assume that by one reason or the other, the kidney starts becoming enlarged by one reason, by a virtue of another pathology. Then I ask you that which vessel do you think is also likely to be affected? It's still going to be the same vessel they will test. So you can think wide and anyhow you can reason it out. That what else can be? What if there is a tumor? What if there is a cancer that the kidney now start enlarging? It can also compress on this vessel. Do you get it? All right. So that's just about this vessel. Don't forget it. Okay. The other things you can see in the kidney, you can see hydronephrosis. So the hydronephrosis may come from ureteropelvic junction obstruction. They can also have stasis. They can have renal stone infection and increased risk of renal cancer. So you don't want to forget this infection. In fact, most of the time, people that have kidney stone, what take them to the hospital is, one of the things that take them to the hospital, because they won't know, is either they are having pain or they are having infection. And this is one of the things they carry risk for renal cancer. Please, I put arrow on them because they can be tested. So just remember, they can form renal stone easily, then infection, then they are at risk of renal cancer. So there is increased risk of UTI in them. For me to write it out like this is one of the things they test very well on the horseshoe kidney. So there is higher incidence in these chromosomal aneuploidy. What are they? If I mention the trisomy that everybody knows, everybody will shout trisomy 13, 18, and 21. So the same trisomies you've mastered. just try to note them again because they can test you on them. Is there another one they can test you on? And that is the Turner syndrome. So Turner syndrome. They can just say there is a patient with web neck, widely spaced nipple, having neck swelling, edema of the. Just put on manner of stuff. You start thinking towards Turner syndrome. And don't forget the cardiac abnormality we mentioned with respect to them, to people with Turner syndrome. Who remembers the cardiac abnormality with them?
Coarctation of the aorta. Oh,
Thank you. All right, those are the two wonderful. We normally use TBC. I expected the person that mentioned coarctation of the aorta to first of all mention the bicuspid aortic valve. It doesn't mean one of them is superior, but if you remember the mnemonic TBC, that will have helped. So bicuspid aortic valve, then coarctation of the aorta. So with renal, horseshoe kidney is another important point you don't want to forget with them. So that's all about the horseshoe kidney, and them just giving you this diagram. So I want you to look at this diagram very well. So I want to bring out a question here. This is horseshoe kidney, as you can see, a kidney here, and they are fused here. As they are fused, they are compressing on, they can compress on these two vessels. Can you see these two big vessels? So if they put an arrow on one of them and ask you that which one is which, these are the two vessels, inferior vena cava and aorta. So these are the two vessels, inferior vena cava and aorta. So they just put arrow on any of them. Which one will you pick for which one? So you just need to look at the shape. Artery has thick wall, so the compression is not going to deform it. So this one that is still in a way or indirectly maintaining its symmetrical shape, that circular shape, concentric shape, you can look at it like that. You take that one for the artery, and that is aorta. The one that is looking a bit deformed, you take that one as the inferior vena cava. So these are just the key points you want to take into the exam here. So let's go through some questions here, just for us to have an idea of how this can be tested in the exam, so that anyhow the question comes, we can have get our answer. A 47-year-old woman comes to the office due to fever, dysuria, and abdominal pain. Sincerely speaking, we don't know what is going on. Anything can give rise to this. Do you get me? So, but definitely you know that this is looking more like urinary tract infection, but you are not really so sure what is going on. Or where it's coming from. I think that's a better way to put it. The patient has had several urinary tract infections since her teens, but has no other medical concern. Now, a physical examination shows mild suprapubic discomfort. Urinalysis demonstrates pyuria and many bacteria. CT scan of the abdomen is shown. So let me show you what they are showing us. So this is what they are showing. So this is the diagram they are showing us in the CT. Can you see? So this one is looking a bit concentric, aorta. This one is looking a bit deformed, IVC. All right. So now say that which of the following structure has most likely limited the proper ascent of the anomalous organs seen on the CT? So which structure are you looking for? What do you think should be the answer?
Inferior mesenteric.
inferior mesenteric.
Inferior mesenteric. So you just pick the option here. So I want you to try this for me, please. You've already solved this, so there is no need of doing this again. So this is another question. A 25-year-old primary gravida at 18-week gestation comes to the office with her husband. Let's meet our mics, please, for routine follow-up. She reports no concerns. An abdominal examination shows normal fundal height. An anatomy ultrasound of the fetus shows male sex. The fetus kidney appear fused at the lower pole and are located low in the abdomen. The remainder of the ultrasound is unremarkable. The couple asks about implication of these findings and the ways they will affect the child after birth. Which of the following is the best response? All right.
C.
C.
How come I've not even finished reading the question? You're already shouting C.
See now, we are reading with you.
I am reading question. You are reading option. How did you know the option? What is supposed to be the right answer? All right.
We are reading with you, sir.
Oh, I agree with you. Okay,
So there
so
are geniuses in this class.
They are ready for exam.
They are really ready.
Now I've watched of you like 3 times.
it's all right. Okay, so definitely here, this is actually a child that is likely going to have, I mean, already has, they are already looking at it, Horseshoe kidney. So what are the complications that you think the patient can develop? Let's list them.
UTI.
Increased risk of
No,
renal
wait. Someone say UTI.
Recurrent UTI.
UTI is wrong. Your recurrent UTI is correct. Anybody can have UTI. Do you get me? So anybody can have UTI. So, but when it start becoming recurrent, something is likely causing it. So recurrent UTI should be the proper answer. So let's look at it like that so that you will master the recurrent. Other stuff are what?
Renal stone.
renal stone, renal C.
Obstruction.
Renal cancer.
Obstruction, then cancer. So you just check, it's actually your duty, just check through the options and see which one fits into any of them. But I told you not to forget recurrent UTI if I thought they overlap. All right, so the answer here is the majority of the patients with this developmental anomaly as asymptomatic basically, but there is an increased risk for what? UTI. So that increased risk plays there or makes them to come down with UTI quite frequently. So you can look at the other options. I want you to pick your answer here for me, please. All right, 68 here. Let me show you the diagram. So what are you seeing here? Horseshoe kidney. This
Horseshoe
is kidney.
kidney.
So what is the origin of the problem?
The IME trapped it from ascending.
So
Inferior post filth.
Fails.
yeah. So okay, oh yeah, pick your answer. Now that we have so many potential answers. So
F.
Okay.
Impaired organ assent.
Impaired organ assent.
Assent. So all right. So that's cool. So that's how they will be tested. Why do you think option D is not likely to be correct?
Incomplete organ fission. No. Are they supposed to fuse before?
All right, that makes sense. You're not even expecting them to fuse before, so that is not what you are expecting. Okay, so that's for this area. Now I want you to come down to this congenital solitary functioning kidney. What is going on here? All right, the thing here is that this is actually a condition of being born with only one functioning kidney. So I want you to pick your, if I told you have a writing material that you can be playing with words there. So this is the first kidney. This is the first kidney. This is the second kidney. So these are the two kidneys the patient should have. So in this kind of congenital solitary functioning kidney, it's only one of them that is functional. This one is non-functional. Now, the question now is that, is it that it's non-functional or is not formed, or it is formed but it is filled with all manner of abnormal connective tissue? Think about it. Is it that it's just non-functional, but the way you define it is that, is it not formed at all, or it is formed but it's filled with a lot of connective tissue? All right, I want you to mark that word, connective tissue. So one of the kidneys functioning, working very well, is already established in the exam. So because in the exam, I am suspecting they will give you the fact that you should make these two diagnoses in the exam. So you will need that explanation to nail it and be like, the answer is unilateral renal agenesis or multicystic dysplastic kidney. All right. So in a general term, congenital solitary functioning kidney means one of them is functioning, the other one is not. And this one that is functioning is going to eventually become, what do you call it, atrophied. Do you get it? Because it's the one doing all the work. It's going to become a bit big. Why this one that is not functioning is going to shrink or become atrophied. All right. How do you want to make the diagnosis? Is diagnosed prenatally via the ultrasound. So now, for the unilateral renal agenesis means this one is not even developed at all. Now, before I even talk about the problem in them, first of all, know that you are going to be looking at focusing on metanephric mesenchyme. Do you get me? You will be looking at metanephric mesenchyme. Please focus on this very well. Be looking at metanephric mesenchyme. This one does not develop at all. How come it doesn't develop at all? And the problem you see here is that what should make the metanephric mesenchyme to also develop is not also developed. So the answer here is ureteric board fail to develop and induce the metanephric mesenchyme. Do you get me? Ureteric board itself does not develop. It's more or less like the whole kidney will not develop. You call that agenesis. Agenesis. The whole kidney is not there right from the beginning. Agenesis. So both ureteric board and metanephric mesenchyme, they are not developed. All right. So now, what about this second one? What you have here is you also focus on metanephric mesenchyme. So what you see here is that you will see that this affected kidney is there, but you don't see most of the nephron part. They are not really that there. And instead of you to see nephron, they are filled with connective tissue. Connective tissue. Never forget this word, connective tissue. Non-functional kidney consisting of cyst and connective tissue. When you see that, you start suspecting the word dysplastic. That's the name. That's where the name is coming from. This. So when you read the question and they tell you in that question that when they do biopsy, they are picking connective tissue and the like, just know that just be looking for the word dysplastic. Multicystic, because it contains cyst, multicystic dysplastic kidney. So that's going to be the answer. All right. And the reason why, so with this one now, you say that ureteric board develops. However, it does not induce differentiation of the metanephric mesenchyme. So that is what we are going to see. It does not induce the differentiation of metanephric mesenchyme. So when you check the question, just be looking for this word connective tissue. When they say they do biopsy and they are picking a lot of connective, the answer is it's most likely going to be multicystic dysplastic kidney. If the kidney is not there at all, the ureter is not there, this one is all manner of stuff, they are not there that are related to this ureteric board and metanephric mesenchyme. You go for unilateral renal agenesis. If they say what do you call it, the ureter may even be there, but the kidney is atrophied, and they do biopsy and they are picking a lot of connective tissue, you start thinking towards this plastic problem. All right, so that's just what I need to show you here. I tried to look for questions to justify this, but I couldn't get. So you can check any question bank, just apply the concept there. You will get the answer 100%. That it won't be difficult. You will even be surprised that you could get the answer easily, because just look for these clinchers here in the question. What about the duplex collecting system? So you just have bifurcation of the collecting board, ureteric board, before it enters the metanephric blastema. So if this is the blastema, before it enters, it can bifurcate into two. Permit me to just show you like this. So it can bifurcate into two. It now depend on the level at which it's bifurcating. So you can have the ureter being 2. You can have the pelvis being 2, ureter being 1. You can have just all manner of stuff, and depending on the way the thing is. So the duplex collecting system can alternatively occur through two ureteric bud reaching and interacting with metanephroblastema. So that's just the duplex, the word duplex. So in the exam, what you need is just the word two. Maybe two two ureter, something related to that, or one ureter that divided into two. Once you are seeing that in the exam, you go for duplex collecting system. So it's just the word of duplex, the same way you understand duplex. All right, what is that thing that it is associated with that you must never forget? So that is that vesico ureteral reflux or ureteral obstruction. So never forget these two pathology. And based on this, the patient is at risk of increased frequency of urinary tract infection. The same urinary tract infection we have been mentioning. So vesico-ureteric reflux, can you see then increased urinary tract infection, risk of recurrent urinary tract infection. All right, so that's that about the duplex. I don't have question there too. I will have shown you. What about the posterior urethral valve question? How do you think the question will come? That will quickly tell you that this is posterior urethral valve. All right, you will see this is going to definitely be a male child. So this is a male child. So, and this child, the posterior urethral valve, please permit me to just look for very good picture to show you, because it will help you to understand the manifestation, the way the patient will present. I want you to be looking at this. So this is actually where the posterior urethral valve is. Can you see? Can you see this valve here? This membrane that is just coming into the lumen. That's actually the posterior urethral valve. So you now imagine that this membrane is now very prominent. So to the point that urine cannot easily flow down. All right. So as the kidney continues to produce urine will just be staying. Will first of all stay here. You call this prostatic urethral area. Can you see it staying? Then in the bladder, it's also going to accumulate there. So urine will accumulate here. It's also going to accumulate here. So when you see urine accumulating here and accumulating here, so when you do all those imaging, you will see something that look like this. You will see something that look like what we normally call keyhole. All right, keyhole. So another thing is this urine that is accumulating here. If at all you will see any urine just finding its way through this place, do you get me? It's going to be very, very narrow. They can easily pass the way, if at all it's not really that bad, like completely obstructed. So, but bottom line of it is that urine is accumulating here, urine is accumulating in the bladder. So as a result of this, when the patient is going to be presenting, that baby will have something that look like suprapubic mass. So a boy that is born, and the question says the boy has a suprapubic mass, and this is a boy. Hope this is not a posterior urethral question. That's just your thinking. Hope this is not posterior urethral question, because this is just someone they just born a few days ago, and the baby is already having a suprapubic mass. When you start seeing that, start suspecting that hope we are not dealing with posterior urethral valve for a boy. So that is that. About that is diagnosed prenatally by bilateral hydronephrosis and dilated or thick wall of the bladder on the ultrasound. So that bladder, you could see how it was thick. Can you see how thick it is? Can you see it's already becoming thickened? All right, so that's that about that. So I put these guys together. Urosepsis in the question. This is a child that is probably maybe having infection that is febrile. The question now mentioned palpable mass, suprapubic mass, or palpable bladder, and there is a history of oligohydramnios in the pregnancy. Until proven otherwise, just quickly rush to posterior urethral valve. This palpable mass, suprapubic mass, will really help you out a lot in identifying it on time. All right. This is the most common cause of bladder outlet obstruction in the male infant. So how are you going to make the diagnosis? When immediately you see this, you're already suspecting. The question talked about, maybe if at all they talk about it, the ultrasound or the presentation of the patient, you already hope this is not posterior urethral valve. The test you are going to do for diagnosis, the investigation of choice that they will test in the exam is voiding cysto-ureterogram. Voiding cysto-ureterogram. So, and what about the treatment? First treatment, you must never forget, if at all they ask about the treatment, you go for cystoscopy with primary valve ablation. They will just try to, that valve that is causing obstruction, they just ablate it, and there will be, urine can easily flow down. All right. If the second one they can talk about is vesicostomy. More likely, are just creating like an opening. I think this one is through the suprapubic area, so I'm not really that. I might not be able to give you detailed information about the procedure, please. So, but this cystoscopy with primary valve ablation. So never forget this. This is the first one in case they test it in the exam. All right. So that's that about the posterior urethral valve. Then another thing you will notice in them is that they must have bilateral hydroureter, ureteral dilation. It is a must. It can never be one of them. So once you are saying it's just one of them that is dilated, then that is not likely to be posterior urethral valve. It must be bilateral hydroureter, because what is causing obstruction is down there. If urine is accumulating here and more urine cannot empty into the bladder, then you are likely going to have bilateral hydroureter, and that's that. Okay, so let me just show you one or two questions for you to have an idea of the way it comes. This is a 12-day-old male newborn who is brought to the emergency department because of a high-grade fever for 3 days. Sincerely speaking, you don't know what is causing the fever. You are still confused, and I don't want you to be reading this question like you already know what the diagnosis will be. So he has been lethargic and not feeding well during this period, 12-day-old. He cries incessantly while passing urine because there is a lot of obstruction. Permit me to just chip that one in. There is no family history of serious illness. He was delivered at 7 weeks. Gestation and pregnancy was complicated by mild oligohydramnios. So we can see oligohydramnios in the question, and this is a child that is having fever. Still, you don't really know what is going on, except something that is what is making this child to cry. We don't know yet. His immunization are up to date. He is at the 35th percentile for length and 40th percentile for weight. His temperature is 39. Pulse is 165, respirations are 60, and blood pressure 55/30. Examination shows open anterior and posterior fontanelle. There is a midline lower abdominal mass extending 2 to 3 centimeters above the symphysis. So this is a child that's usually strained, a male child strained. More or less like crying while urinating. That's what I was supposed to say, sorry. So having fever, and you are seeing suprapubic mass. Cardiopulmonary examination shows no abnormality. The child is diagnosed with urinary tract infection, and broad-spectrum antibiotic is begun. The patient will most likely benefit from which of the following? So what is the diagnosis here? And that is posterior urethral valve. Being a male, you can see fever, urosepsis likely. You can see a suprapubic mass, and you can see crying while passing urine because of obstruction. So they now ask you that, what do you want to do? So if you look here, the answer here is just ablation.
Yeah, ablation.
Ablation is what you are going to go for, not the vesicostomy. Because vesicostomy is also there. You don't want to rush there. Do you get me? So vesicostomy is there so that you won't be saying, I saw. It is the second choice. So it's second choice. I think it's when the specialist hand to do this first procedure is not there, it's not available, or they can't do it, that's when they just try to just relieve the obstruction, to relieve the urinary retention that the child is probably having, so with this procedure. So I'm not sure, I don't know detail about that, but this is not the definitive treatment you are looking for in the exam. I want you to try this, everyone, for me, please. So a 2.5 kg male newborn is delivered at 35-week gestation to a 25-year-old woman, gravida 2, para 1. The pregnancy was complicated by oligohydramnios. Pulse oximetry on room here shows an oxygen saturation of 78%. Examination in the delivery room showed that the newborn skin appears blue. He has a weak cry with irregular breathing and gasping. The nose is flattened with prominent bilateral epicanthal fold. The hairs are low set with broad auricles. The lower jaw is abnormally displaced backward. The right lower limb appears shorter than the left lower limb with displaced right great toe. Breast sound are decreased bilaterally. Renal ultrasound show bilateral dilatation of the renal pelvis and the ureter, bilateral. And this is a male newborn. Which of the following is the most likely to confirm the underlying cause here? So what's the answer?
A.
For
Voiding
system
ureteral.
Exactly. All right, so that's very correct. So please never forget these two guys in case they mention them in the exam. Now, what about the vesicoureteral reflux? So I just want you to be noting, not to be noting stuff, just to be like, okay, when I see bilateral and this is a male child, so what can they ask me? Okay, first diagnosis, second one, what do I want to do in case they ask me? So that you won't say you don't know. So what about the vesicoureteral reflux? What do you want to take into the exam with respect to this guy? One, this is actually, let me show you something in the diagram. Don't be annoyed with me, just be flowing with what I'm trying to show you. Let's look for a diagram that will help. I'm not sure this will. Okay, okay, let me just use this to explain it. No, 1 minute, please. Let's see if this will show. Okay, let's use this to explain it. This is better. All right. So what is happening in vesicoureteral? Look at this ureter. Just be following my cursor. This ureter, the way God did it is in such a way that there is no valve here. Ureter empty. In fact, it buries itself within the wall of the bladder. So, depending on the length of the ureter that actually span through the wall, that would determine whether during urination, when the bladder is contracting, that bladder contraction will squeeze this area. That bladder contraction will now should actually close up this what do you call it? This ureter, this intramural ureter. Do you get me? So that urine will not flow back during that bladder contraction when I want to urinate, when the patient wants to urinate. So now a patient that is now having, you now imagine, let me sketch something here before we come down back there. So this is the bladder, this is the bladder, but this is the wall of the bladder. So now this is the ureter. This is the normal ureter. Permit me to show you like this. So the ureter for the vesicoureteral reflux is like this. So I want you to look at the length that is span by this ureter within the wall. So this is the length span here. Can you see? And this is the length span here. So because the closing up of this intramural part of the ureter is dependent on the bladder contraction and the length that span, because this adequate length span through the wall, this one is like the patient is not likely going to have a reflux here. Now this one that the ureter is entering the the bladder acutely. Is it acutely? I'm going to put it more or less like it's just entering it, not that it's first of all spanning it. Do you get me? And now entering it just like the normal one. So when the bladder contracts here, this area is not going to adequately close up. So this patient is going to have reflux. All right. Now that is actually what you are seeing in this diagram here. So this one normally, so you are seeing it like this because the length that spans through the wall is not enough. It's a very short length. Please mark everything I'm saying, because these are the things they will ask in the exam. It's a very short length, very simple things they ask. So then urine can easily go back. All right. Now there is something we call so this can actually be primary. So it can also be secondary. Primarily means that the problem here is related to this area. Secondary means that there is no problem with this area. This baby is just having a lower down obstruction, that when the bladder starts contracting, urine cannot flow forward. So there now exists a backflow into this area. That's the secondary one. So that's secondary one. So never forget this. So when you are seeing vesicoureteral reflux, you can see it in a patient that is actually having like a male child with posterior urethral valve, or a adult patient with maybe BP, BP8 and the likes. All right, so just don't forget this at all. Okay. All right, so urine is going back. Now, urine that is going back, if it continues, this ureter start dilating. Do you get me? And apart from the ureter, the pelvis and the like, they start dilating. All right, I need to mention all this stuff because I'm going to introduce something to you now. Okay, and this is what I'm going to introduce to you. So this is what I want to introduce to you. So I want you to look at this image very well so that when you read the question, you have an idea of what is going on. So we have grade. I'm not showing you this picture to cram any grade here, but there is an understanding I want you to have that you'll be using to read the question. For the grade 1, urine is only refluxing into the ureter. For the grade 2, it can reflux up to the pelvis and calyx, but there is no dilation in these two guys. There is no dilation at all. Even though there is reflux, there is no dilation. So these other guys, grade 3, grade 4, grade 5, you have dilation. I just want you to note that. So when you read question and they say they do investigation, there is no dilation. No, you are only dealing with grade 1 and 2. If there is dilation, you are dealing with grade 3, 4, and 5. Just note it like that. That's all I need from you. So then you come down, you take that understanding down to the way the patient is going to present. So this patient is going to be a child. It can also be an adult, but commonly a child with recurrent urinary tract infection. So I put something here, a child with recurrent urinary tract infection question. The first differential, whether it's USMLE step 1, step 2, step 3, you are doing, just first of all say, once you hear a child, and they say this is the second or third time they are treating this child for UTI, say, hope this child is not having vesicoureteral reflux. Just say it. Be like, how? You say, this is a child with recurrent urinary tract infection. Hope, that's the statement. Hope this child is not having first cycle ureteral reflux. All right. So please never forget that. So you just read the question, you see this is a child with this kind of picture, recurrent urinary tract infection. Just go straight to the option. Are you asking me for the diagnosis? If they say yeah, just pick first cycle ureteral reflux and go and mark yourself. Go and check the answer. You are most likely going to be correct. The reason why I need to state it that way is that it might be just 10 seconds or 15 seconds you have left before that might even be the last question for that block, and you just see a child with recurrent urinary tract infection and you are now like, I didn't finish the question. Who told you need to finish that kind of question? Just go to the option and pick first cycle ureteral reflux. Most likely going to be correct. Now, I put something here. Now, this child has come. You are seeing recurrent urinary tract infection. So, the next thing you want to do is just more or less like, let's do ultrasound. Because you are not still sure that, let's check with ultrasound what is going on. The now question I say they've done ultrasound and they are seeing evidence of hydronephrosis. They are seeing evidence of hydronephrosis, dilation of those ureter, pelvis, and the like. They are seeing evidence of that. You go at that moment. You go and perform voiding cysto-ureterogram. All right, so that you now be able to grade the whole stuff the way you are supposed to grade it. So this is actually the main test, voiding cysto-ureterogram. Never forget it in case they ask you. Now, if you look at the question, there is no dilation in the question. This is actually supposed to be 1 to 2, according to that diagram I show you. So there is no dilation. If they ask you that, what do you want to do for this patient? The only thing is conservative management. Treat that UTI and just place the patient on prophylactic antibiotic, because the patient is at risk of coming down with this recurrent UTI. It will be there. So other things is to now do some behavioral modification, like avoid constipation, so that the patient will not be constipated to now be straining for more reflux to now be occurring. So this prophylactic antibiotic is not a joke. So what if the question says, and when they now do ultrasound, they are seeing dilation? Once you start seeing dilation, or the question is talking about bilateral grade 3 and all manner of so, once there is shared dilation, the next thing is, apart from prophylactic antibiotic, is surgery. You need to go and do surgery. Once there is dilation, think about surgery. If there is no dilation, only conservative. And what are the components of that conservative? Prophylactic antibiotic and behavioral modification. What about the severe one? Surgery, then prophylactic antibiotic. So never forget prophylactic antibiotic, because they are at risk of recurrent UTI. What are the complications the patient can have? The complication the patient can have, first of all, is recurrent UTI that I've mentioned. Recurrent UTI. Another one is CKD. So scarring can occur. Scarring, because if someone is having a lot of pressure, reflux all the time, so there can be scarring, which can also come from CKD. All right, so please let's note this first cycle ureteral reflux in case they are giving you this kind of question. So I want you to look at this question for me, just for you to have we might not be able to solve all of them. I just want you to have an idea of how the questions in the exam are likely going to present. A 4-month-old girl is diagnosed with febrile urinary tract infection. A voiding cysto-ureterogram shows retrograde urine flow into the right ureter, but no associated ureteral dilation. 1 year later, a voiding cysto-ureterogram is repeated and shows no abnormalities. Which of the following is the most likely cause of this infant presentation? What do you think is likely the cause? Because there is nothing that could have caused it. This is just a girl. So where is you'll be thinking towards congenital short intravesical ureteral
of the
length.
ureter.
Exactly. So that's what so I want you to look at this for me. So a 9-month-old girl is brought to the clinic by her mother for follow-up after completing a course of antibiotic for her first febrile urinary tract infection. The patient is now afebrile with no symptom. Vital signs and visualization are normal. Renal ultrasound reveal unilateral hydronephrosis. How are we having hydronephrosis? That's a voiding cysto-ureterogram reveal unilateral retrograde urine flow into the ureter and collecting the with dilation and blunting of the renal kidney. So this is vesicoureteral reflux. Which of the following is the most appropriate next step here that you want to do? What do you think should be the most appropriate next step for this patient? Anyone?
Prophylactic antibiotics.
It's
Just
antibiotic.
place them on antibiotic. So never forget that in case that is tested. Let me show you another one. A 4-year-old boy is brought to the clinic for evaluation of fever, pain with urination. The fever began yesterday morning, and in the evening, the patient would cry while urinating. Ibuprofen improved his fever and pain, but he began to vomit this morning. Medical history includes febrile urinary tract infection at the age of 13 months that resolved after a course of antibiotic. At that time, a renal and bladder ultrasound was normal. Temperature is very high. Palpation elicits suprapubic and right-sided costovertebral angle tenderness. When you start seeing this costovertebral angle tenderness, you start thinking more towards something like what do you call it, pyelonephritis. So urinalysis revealed positive nitrite and leukocyte esterase. A urine culture showed more than 100,000 colony forming units of E. coli. The patient is now given antibiotic and his symptom resolved. A repeat renal bladder ultrasound is normal. Which of the following is the best next step? So what do you think should be the best next step for this patient? Anyone?
Voiding cysto-ureterogram.
Voiding cysto-ureterogram. So why this patient is okay now and
Since she's okay now, maybe it's to repeat or something. Or be no additional. Okay.
So what about the daily antibiotic prophylaxis? You don't think this patient actually needs it?
Oh, wait.
Do you get it? So
Yeah.
I feel that should actually be the next thing. Anyway, let's check what they pick as their next thing. All right, that's voiding cysto-ureterogram. Haven't they done that one?
They said the patient is giving antibiotics.
Okay, the patient is already giving antibiotic?
Yes.
All right.
Yes.
So since the patient is already giving antibiotics, so that should be the next one. I want you to try another one. Thanks for noting that. There is a particular girl here that is crying, so distracting me. So I want you to look at this. Though I never mentioned any. Did I mention any antibiotic that you can give? Okay, but let's just give it a try. Let us assume that this is the same picture. Which antibiotic do you think you want to give to the patient, this child?
Zetro.
So it should actually be something like cefizine. Usually, it should be something like cefizine. Like, what do you call it? Cephalosporin. Yeah, so that should be the antibiotic they give. So, all right, that's very correct. Okay, let me see if at all. Just look at it for me and read the question when you are going through all these stuff. So this is a diagnosis for you to make here. This is another one for you to make. Sorry, let me enlarge it for you so that we can go to the next one. So can you see? So this is another one. All right, so that's all the questions I have for you here. So try to go through them very well. So now you come down to the anatomy. This is the renal blood flow. So what do you want to take into the exam? Is it the picture? Do you need to cram the diagram? You don't need to cram the diagram at all. Like, don't cram any diagram here. You don't need it. Okay, so the first point is this. You want to understand the concept behind the left renal vein. What is it about the left renal vein? Left renal vein, one, it is longer. It's longer. So this is the right, this is the left. On the right, so this is what we have. You have the inferior vena cava here. You have the aorta here. So the left renal vein, we now need to travel this length to come and empty here. Can you see? Now look at the right renal vein. This is it. So this is very, very long. So because of this, most of the time when they want to do, let me say they want to do renal transplant, it is actually the left kidney most of the time that they want to use because of these attributes. It has a longer, what do you call it? Longer vein. So in case that is tested, you can easily pick your answer. So another important point you want to note here is that this left renal vein has two additional veins emptying into it, the left suprarenal vein and the left gonadal vein. So if at all anything happens to this left renal vein, there is an obstruction. So these two vessels will not be able to empty the way they should. So when you check the patient, so you are going to be seeing what? What are you going to be seeing for this left gonadal that's not? What will you be seeing?
Varicose.
Varicose.
Very person.
Exactly. So you'll be seeing varicose. You just want to note this and rehearse it very well. Just a very simple concept. There is nothing there. It's very long, and you see all these two other vessels emptying into it. Okay, so that's the first one. Another second point I want you to note is the way God really did this blood supply. Now, the way this blood supply looks for the kidney is that this is actually the kidney. So you have the cortex here and you have the medulla inside. So let us use arbitrary division here. So if blood enters the kidney, so this junction, you can give it a special name called corticomedullary junction. Corticomedullary junction. So what happens is this. When blood enters the kidney, it will first of all go supply the cortex. After supplying the cortex, it's now going to turn back to now start supplying the medulla. Can you see? It will first of all, so cortex, you hardly see cortex being damaged by lack of oxygen. If at all anything happens to this this blood vessel, so where you are likely going to see ischemic injury is likely going to be the medulla. Why? Because the medulla does not really receive, it's just managing the oxygen. Do you get me? So you now still go and reduce the little it's getting. So the medulla, the nephron in the medulla will start dying. So they start dying. This way the blood is supplied to the kidney, you must note it and take that concept into the exam. So they may just give you a question and just say that maybe something happened to the patient, had a road traffic accident, had this, had that. Now, which part of the kidney is most likely to be affected by the hypotension the patient suffer? The answer is going to be the medulla. Just pick the medulla and go. So that is that, because the medulla is very sensitive, very, very sensitive to hypoxia and vulnerable to ischemic damage, because in natural sense, it doesn't really receive much. And this is the second concept they want you to bring into the exam, which you will have even written by yourself. It's not that maybe you need to have read all the nephrology book in this world before you pick that. And there is nothing difficult about this. All right. So the last one is about the renal transplant that I mentioned, so which you can join it to the first concept I mentioned, and that's all they want you to pick here. You don't need to cram anything like segmental artery, interlobar artery, arcuate. You don't need them at all. You are not an anatomist, and no one will really test. There is no clinical significance you can attach to it with respect to USMLE for the exam, unless someone wants to set a pathological question out here. because you are not going to see a patient and be shouting it is aqueous artery that is affecting you. So maybe when someone is writing some paper, you can be going deeper, but this is like the foundational knowledge you don't want to forget. What about the glomerular anatomy? Now, you want to master what you call justa glomerular apparatus. What do we mean by justa? Justa means just around the glomerulus, you see these guys. Around the glomerulus, you see these guys. There are 3 in number. We have the macula densa. So look at this macula densa. Can you see? They are just these endothelial cells you are seeing here. So they are quite specialized to sense the sodium chloride. This is the glomerulus. So the second one is justa glomerular cells. So these are the specialized smooth muscle cells. Can you see them? Justa glomerular cells. They release Renal. So you want to get used to them. So the only one that has letter R in his name is this guy. So is this guy. So and is the one releasing Renal. Justa glomerular cells is the one releasing Renal. In case you are doubting which one is sensing sodium chloride, which one is releasing Renal. So that's the concept here. The last one is the mesangial cell. When I'm talking about diabetic nephropathy, I'm going to unravel the mystery behind these mesangial cells for you. So, but these are just the third one. These 3 guys, you want to get so used to them, say them, turn them to reading, mention them, use them to abuse your enemy. Be like, well, it's actually the justa glomerular enemies that are actually like, you know, when the enemy that is closer to the friend, again, is a justa glomerular enemy. All right, you can look at it anyhow you want to look at it, but just don't forget them. Write them down, rehearse them. The question they will ask will be related to what they do. So this macula densa will sense sodium chloride. The justa glomerular cells will release Renal. The mesangial cell will actually respond. There is a way they respond to the pressure that they are experiencing within the glomerular pressure. Okay, so that's that about this guy. What about the vessel? You have the afferent arteriole. They bring blood to the glomerulus. Efferent arteriole takes blood away from the glomerulus. Is there anything quite special about this guy you want to take into the exam? Yes. What I want you to note is this letter. I want you to note this letter A for the afferent, letter E for the efferent. Letter A for the afferent. You need to practice it to get used to it. So, for the letter A for the afferent, you are going to be relating it to PDA. For the letter E for the efferent, you will be relating it to ACE, angiotensin converting enzyme. Probably, if that makes sense, ACE. So what this means is that prostaglandin will dilate the afferent. What this means is that angiotensin 2 will constrict the efferent. So when they give you any drug in the exam, your assignment is to check, is this drug going to reduce the level of prostaglandin or affecting the level of angiotensin 2? Any drug they are giving you, you just check. Just ask yourself, this drug you are giving, is it affecting the prostaglandin or is affecting the angiotensin 2? So when you establish that, you are already 70% closer to the answer, because you can now be like, okay, if it is affecting the prostaglandin, let us say it's reducing the level of prostaglandin, it shows that the afferent arteriole that should dilate when prostaglandin level is optimal, they will now be constricting. So if the drug is reducing the level of angiotensin 2, it shows that the constriction you should be seeing with angiotensin 2 effect on the efferent, you won't really see it again, because there is reduction in angiotensin 2. So your assignment is just to play, they will just be playing around that, which I don't think is quite, there is nothing complex about it. To be very sincere, I used to say it, we can work on qualitative reasoning on all these things. We can oversimplify medicine right from the primary school. So I think this is one of the reasons why we are studying it. It's one of the things that anyone that can look into it can actually work on. And just say that NSAID reduce the level of this. What do you think will happen to this? This one will reduce in size, this one will dilate. So let us do some qualitative reasoning now. So if at all there is a drug, you look at the drug, the net effect of that drug is dilation. So if this area should dilate, this vessel should dilate, and nothing happens to this one, it's still the way it is, more blood will flow into the glomerulus. So, and that more blood that is flowing, they are not leaving because nothing is happening to the efferent arteriole. So that will raise the intraglomerular pressure. If you are having raised intraglomerular pressure, more fluid will be filtered. It's more or less like when you want to sieve ogi and you are now turning the neck, you are twisting the cloth where you are using to sieve ogi, pap. So you are twisting it, more fluid will be going out because you are increasing pressure within that sac that siever that we normally use. So that is what is happening. If you make some holes in your pure water and you are now squeeze it, you will see the rate at which that water will be ejecting out. That is same thing that is happening here. So when you raise the intraglomerular pressure, you just say it and be like GFR is going to rise. That's all you want to note there. Okay, so that's the first concept. Let me try to give you another thing. Another thing they will ask you here is that what do you think is going to happen to the renal blood flow? Once any of these vessels dilate, renal blood flow will increase. Once any of these vessels dilate, renal blood flow is going to increase. If it is afferent that dilate, renal blood flow will increase. If it is efferent that dilate, renal blood flow will increase. If the afferent constrict, renal blood flow will reduce. If the efferent constrict, renal blood flow will reduce. So never forget that anything that happens to any of these vessels will also affect the renal blood flow. It's just as easy as that. So if the question says the patient is having, maybe there is the net effect of afferent constriction, vasoconstriction, afferent arterial constriction, then you say renal blood flow will reduce. If the question is saying there is efferent constriction, you also say renal blood flow will reduce. If they say efferent is dilating, you say renal blood flow will increase. If they say afferent is dilating, you also say renal blood flow will increase. So there is nothing too logical. There is no logic there. It dilates, it increases. Any of them, it reduces. It constricts, it reduces. So that's that about the renal blood flow and the way you'll be looking at it. All right, so I think that's basically what I need to show you here that you can take into the exam. We'll be complicating the matter gradually as we go. So you come down to this area, the course of the ureter, the way the ureter actually moves. I'm going to leave you with two wonderful concepts here. This is the first concept. The first concept is here, and this thing I wrote here is the second concept. So I just want you to get it. There is a way they used to say it when we were in school, that water under the bridge. Water under the bridge. The bridge. All right, if they say water under the bridge, just draw the bridge. This is the bridge, label it as the bridge, and this is the water. What is that water? Is the urine. So water under the bridge. So this bridge that they are giving us here is actually the uterine artery. Uterine artery. So water under the bridge, this is urine. So it shows that you find ureter under the uterine artery. That's all they need from you. You find ureter, it causes under the uterine artery, water under the bridge. So I also put something. I had another one, overcomer. Overcomer. Once you master this, you become an overcomer. What is overcomer? This water is actually over something, and that thing is over is the common iliac artery. So you are dealing with this is this is like your reference landmark. Water under the bridge, over, comma. Water under the bridge, over, comma. So anyhow the question is given, is it above the common iliac artery or is underneath it? Anyhow they are given, you can easily use this to over, comma, and under uterine artery to answer that question. So it's quite straightforward. To the best of my knowledge, I feel this is straightforward. All you need to do is just to write it down and you will be fine. All right, the next concept I want to leave with us is, if the question is about what will happen or the structures, the way the ureter actually is related to the structures around it within the peritoneum, when it's moving towards the true pelvis and when it's within the true pelvis. So in the exam you are looking for the word, is this question asking me the way the ureter is related to structures within the pelvis, or towards the true pelvis, or within the true pelvis? These are the 3 questions you are asking yourself. Is it within the peritoneum, towards the true pelvis, or within the true pelvis? Now, ureter passes posterior to the ovarian vessel within the peritoneum. So peritoneum starts with letter P. This is also going to be posterior. You just need to rehearse it. All right, you can look at it like that if you wish. If it doesn't make any sense to you, please just discard it. Towards the true pelvis. So when we start talking, the question start talking about pelvis, you start talking about the what do you call it? Ureter actually lying anterior. So within the peritoneum it is posterior. Towards the true pelvis and within the true pelvis is actually anterior. All right, so I already know that all my thinking here is going to be posterior. All my thinking here will be anterior. I will now look at the word towards. So anterior to what? Towards external iliac artery. External, towards external iliac artery. Then within is going to give me internal iliac artery. So anyhow the question comes, I will just look at it. Is this question talking about peritoneal relationship, or towards the true pelvis, or within the true pelvis relationship? If it's pelvic, whether towards the true pelvis or within the true pelvis, I will be thinking towards anterior. If it's peritoneum I'm seeing in question, I'll be thinking towards posterior. That is, ureter is actually lying posterior in the peritoneum, and ureter is lying anterior in relation to either towards the true pelvis or within the true pelvis. So to which vessel now? I will just go for something like for the what do you call it? Towards the true pelvis, that would be external iliac artery. Another one is the common iliac artery, external and common. So within is going to be anterior to the internal iliac artery. And these are the concepts I want you to pick. 2 basic concepts I want you to pick with respect to the course of the ureter for the USMLE examination. So the other point I just want to make, which does not necessarily mean that so one of them, I think they tested it before, is this gynecological procedure, because in the course of ligating any of those vessels that they are related to, depending on where the patient is having the operation, they can ligate the ureter together with such vessel. So they can ligate it. The question we just said that after the procedure, the patient can no longer produce urine. So probably maybe that might even be the only functional this thing in the or the patient start having hydroureter and the likes, depending on where the way they just know that they can mistakenly ligate it. So God have mercy on us. I won't say more than that. All right, then also the blood supply to the ureter. So if it's proximal, you will be thinking towards renal artery because it's closer to the main body of the kidney. For the middle, you'll be thinking towards gonadal artery, aorta, common iliac artery, and I usually used to put one mnemonic here. I think Gazi or something like that. I can't remember. So, which I'm not saying that that's what you should use. So, whereas for the distal, it is closer to the bladder. You'll be thinking towards superior vesical artery and internal iliac artery. All right, that's with respect to the blood supply to the ureter. Okay, we've talked about two wonderful places where patients can have obstruction. Ureteropelvic junction is there. Ureterovesical junction is there. Then another one is pelvic inlet. So, and that's all about the ureter here. Let me just show you this question. I think this is quite easier. So, a 40-year-old non-gravid woman comes to the office with a 2-month history of worsening right pelvic pain. She experiences the pain daily and its intensity does not vary during her menstrual cycle. In addition, the patient's waist size has increased despite a decreased appetite. That's the waist size. Pelvic examination shows an irregularly shaped fixed adnexia mass. 1 week later, she undergoes surgery to remove a large ovarian neoplasm. Within the true pelvis, the surgeon can most likely palpate the right ureter immediately anterior to which structure? So which structure do you think is lying anterior to it within the true pelvis?
Internal iliac artery.
Internal iliac artery. So that's just how you can relate that one to towards the true pelvis question and see how they are. All right, so what I will do is to allow you to go for break now of 20 minutes. Then we come back and start the renal physiology. Thank you. All right, so this is actually the renal physiology. How do we want to be looking at it in the exam? You don't have much to put at the back of your mind here. First of all, just be picking them one by one, just few points. The first one we will look at is the fluid compartment. All right. We have what we call the intracellular fluid. We have the extracellular fluid. So intracellular fluid just means within the vessel. Any other place where the fluid exists in the body, within the cell, I wanted to say intracellular fluid within the cell. So any other place where the fluid exists in the body outside of the cell is the extracellular. So intracellular makes up like 2/3 of the total fluid you can talk about, while the extracellular makes up the remaining 1/3. Okay, so in the exam, anytime you see that this question is related to fluid compartment, just tie their destiny. Tie the question. So TIA. Just use the rule of 60-40-20 tie. 60-40-20 tie. 60-40-20 tie. We brought out tie in the GI. You remember? Who remembers what we ice tie? Who remember that? Do you remember it?
Yes.
Lovely.
Yeah,
So
the ligaments and
Yes.
exactly. So the fascia and the likes for the spermatic stuff, where they are all coming from. Okay, so don't forget. So for here, it's just a tie, 60-40-20 tie. So what this 60 means is that they will give you the body mass. 60% of it is actually what we give you the total body water. That is this T, while the 40% of it, of this 70, we give you the intracellular fluid, while the 20% of this 70 we give you the extracellular fluid. Can you see? Quite easy and straightforward. So in the exam now, if they say the weight of the patient is 70 kg, they now say what is the total body water. So you can help me look for 60% of it. multiplied by 70. So this one will be 42. 40% of it, that's 28. Hope I'm right. Then 20%, that's 14. All right, so the extracellular is 14, the intracellular is 28, the total body water is 42. Chicken. So that's just how you'll be using, so that you won't be struggling with the percentage. What is the percentage of this? You don't need to let the struggle end and just be using 60, 40, 20 tie. So it will help you out in case they ask you to calculate anything here. All right. So extracellular fluid, basically this E here, extracellular, that's 20%. You have the interstitial, you have the plasma. Interstitial is 3/3. Plasma is 3/4. Plasma is just 1/4. So 25% for the plasma out of this E, 75% for the interstitial fluid. So which means that when you calculate your extracellular fluid, you got 14. I think we got 14. All right. So they now say what's the plasma volume? Plasma volume will just be 1/4 of this. Interstitial will be 3/4 of this. So 14 multiplied by 0.75 will give me 10.5. This one will be 10.5. So why this one will be 3.5? So 3.5 will be my plasma. 10.5 is going to be my interstitial. All right. So that is for the extracellular volume. That's the only one they can also ask you to break down. So you don't need to break any other one down again. So just 3/4 for the interstitial, 1/4 for the plasma. So the question might just be, what's the plasma volume? First of all, apply this rule to get your extracellular fluid volume, then divide it into 3/4 and 1/4. 1/4 for the plasma, 3/4 for the interstitial fluid. All right, so that's that about the fluid volume, in case they say calculate it. Now, what is our intracellular area? What are our intracellular area? The most important one for the intracellular is the potassium and phosphate. Potassium, then organic phosphate. Please, like ATP and the likes, don't forget this potassium. Magnesium is also there. For the extracellular fluid, you'll be thinking more towards sodium, chloride, bicarbonate. So just remember sodium very well. Extracellular, sodium, this is the positive charge. The negative charge is chloride and bicarbonate. When we get to acid-base disorder, you will see how we'll be applying this very, very well. So extracellular, you have sodium, you have chloride, you have bicarbonate. So what happens in the extracellular is that if the bicarbonate is rising, chloride will be falling. If the chloride is rising, bicarbonate will be falling. So two of them will never rise together. They don't rise together. So it's very rare for you to see them like that. Let me put it that way. So chloride is rising, bicarbonate will be falling. What that means is that in the exam, like this is a patient, and they now say that they are giving the patient sodium chloride. This patient, they just rush the patient to the emergency, and the physician is just like, in fact, it's a question, USMLE question. They are giving sodium chloride. So if you are giving sodium chloride, where are you putting the fluid? You say inside the vessel. So which is going to fall under the canopy of extracellular fluid. So then you are giving what's the sodium chloride, sodium and chloride. What happens is that bicarbonate will be falling, and this can tilt the patient to what you call metabolic acidosis. All right. So some people used to say that sodium chloride is just normal saline. It's just a normal saline. You can give it to anybody. It's a lie. So there are so many people that have died all because of the fluid that was wrongly given. So the diagnosis was not made, and they were giving fluid that worsened the diagnosis, and the patient just ended up dying. And I'll be like, no, it's not medical error. It might just be from fluid alone. So please don't forget this. Just rehearse it. I predicted it, and later we eventually saw it. I just predicted it that they can say something like that, then later we saw something like that. All right, so you also can predict, just look at it and just predict it. Okay, so that's with respect to this area. You don't
How
need
did you
to
predict? Sorry.
that blood volume that can be given. Like they will just say that this patient was given normal saline, blah blah blah, and the like. All right, so in case they bring it out again, we'll still look at it more clearly. So all this serum osmolality, the normal one is 275 to 295. Just note it. Plasma volume is this total blood volume multiplied by the 1 minus hematocrit. So you don't need to cram me this. Where you need to note it, I will show you. So that is all about this area. Just rehearse it very, very well. The other important aspect of it that I didn't mention, I will mention them later. What about the glomerular filtration rate? So barrier, what do you want to note here? How is this barrier formed? And we are going to look at how it is formed and the likely questions they can bring from them, because I don't have any question here. So what is it made of? You have these fenestrated capillary endothelium. So these are the guys. They are great guys. Can you see them? They are great guys. Then God did not just leave them like that. God placed them on a beautiful mat. And this is the mat. So you call it basement membrane. Sit down and flourish. So another thing about these guys is that they are fenestrated, which means something can pass through them. So let us look at it like this. They are fenestrated. Okay, so permit me to just represent them like that. So what is it about this basement membrane? It is made up of type 4 collagen. This type 4 collagen. So in biochemistry, we'll be looking at all those collagen abnormality. So you can easily relate it to this area. So it's made of type 4 collagen and heparan sulfate. Don't need to bother yourself about heparan sulfate. Just know the type 4 collagen, basement membrane. All right. Then we now have what we call the visceral epithelial layer. So where you have food processes. Let me represent those food processes like this. So they are like this. You have this as the food process. Okay, so they are here. Permit me to just represent them like that. So this is just the glomerular filtration barrier. So we have two wonderful barriers here. We have the charge barrier. We have the size barrier. All right. The charge barrier means that this basement membrane is negatively charged. So which means anything that is negatively charged, we find it difficult to pass, because like charge we repel, unlike charges we attract. So what are those molecules that are also negatively charged? A very good example is protein like albumin. So you do not expect albumin to actually be in the urine, because it is negatively charged and is going to be repelled by this negatively charged barrier. So that is number one. Then we come down to the size barrier. So fenestrated capillary, this is actually what is mediating it. So, and the podocyte, this one on top here and the one below here, they offer the size barrier. So beyond a particular size, those molecules will not be able to pass, like more than 100 nanometer. They won't be able to pass. They won't be able to pass through this fenestrated capillary and also, what do we call it? The podocyte food processes and the like. All right. So definitely just know that larger molecules are not supposed to pass. You don't really need to bother yourself about the sizes, the different sizes we are seeing here. Just know larger molecules are not supposed to pass. Then negatively charged molecules are also not supposed to pass. So what can make albumin to pass here is if we have some antibodies that come, they neutralize this negative charge, or something happened, this negatively charged basement membrane is now neutralized. So you now start seeing albumin passing through and finding its way into the urine. So never forget this condition: negatively charged molecules are not supposed to pass. And that is all they want you to bring to the exam here. That's all, nothing more than this. Now, this is where you need to wake up if you are sleeping, because once I establish the equation, we are using it, and other people start applying the equation or the formula, and they are getting the answer, I will not come back. So if you are sleeping, wake up. If it doesn't interest you, continue your sleep. Okay, so we call this area renal clearance. So think about it. When you hear the word clearance, what are you clearing? You are moving something from a place and putting it into another place. That's clearance. So it's a clearance with respect to that particular area where you are removing it. So what we have here is you can move a substance from the blood. You can move a substance from the blood. You can move a substance from the blood, remove it, remove from blood, and put it into the urine. Put in urine. All right, you can look at it like that. So basically, remove from blood, put it in urine. What are we removing? If I remove 4 grams of a substance from the blood, then where am I putting it? I'm definitely putting it in the urine. It will also be 4 grams. It won't reduce. It won't reduce. So if I remove 4 grams from the blood, I'm also going to be putting 4 grams in the urine. And if I turn this thing to rate, so the rate at which I'm removing it from the blood, it will definitely be equal to the rate at which I'm removing it, I'm putting it into the urine. Because I pick it somewhere, I put it somewhere. The rate at which I'm removing it is also going to be the same rate I'm putting it the other place. Very easy and straightforward. All right, this is more or less like a background information for us. So now, when we're in secondary school, they taught us in chemistry that mass, or you say concentration, is equal to mass over volume. All right, so mass over volume. So which you can say that mass is equal to concentration times volume. Mass is equal to CV. All right, so I can come here now and say that the mass that I'm removing from the blood, let me put it inside like plasma, is equal to the mass I'm putting. I'm not writing all these things to waste your time, but so that you won't end up cramming anything into the urine. The mass I'm putting there. And if I put it into rate over time, it will also be the same thing. Then if I now want to say, what is my mass? Concentration multiplied by volume divided by time, abi? So I will put this as plasma. You don't need to cram any formula. This also will be concentration multiplied by volume divided by time. I will turn this one to urine. All right. You see this volume over time. Volume over time is what you call clearance. So that is actually the main term, clearance. So you can come here now and say that this is the clearance from the plasma. This volume over time here. And this one, I will take it as something that look like my clearance from the urine. And this clearance from the urine, they give it a special name. You call it urine flow rate. So here now, I will be reserving this word for clearance, this volume over time here for clearance. Here, I will be calling this clearance, and I will be calling this urine flow rate. I think they represent it with V or U. So you don't need to use what they use. Yeah, it's V. So V. All right. So that is that. Can you see the way we arrived here? So you don't need to be proving, just so that when you are reading question, it is the understanding of this you will be using to answer all questions, so that you won't be saying that They are saying this also mass left the urine. Left the blood, the plasma. This also mass is in the plasma. So if the question says 40 gram is leaving the plasma, then when they check the urine, they are saying 30 gram. It means the substance is reabsorbed, because I'm supposed to see 40 in the urine. You now check the urine, you are seeing 30. Where did 10 go? Then something has taken it up. So if the question says 40 is leaving the plasma, and when they check the urine, they are seeing 50, then the kidney itself is secreting that substance. It's not only filtered, it's also secreted. That is how you'll be looking, because you expect them to be equal, but they are not equal. Anyhow, the question is now going, you just need to look at it and be like, why are they not equal? Very easy and straightforward. All right. So this formula I've written here now, I will just say here and just say clearance, concentration multiplied by volume over time. I'm okay with the word volume over time. I will just write this formula the way I have written it down here, and I will just be using it like that. Concentration multiplied by volume over time, bracket plasma. Concentration multiplied by volume over time, bracket urine. That's all. You now check which of the parameters is given to you. So they will give you this volume over time with respect to the plasma as clearance. They will give you the volume over time with respect to the urine as urine flow rate. That's how they will give it. So, and that is how you will be using it. Any substance at all, this is the formula you will be using. So if our clearance is less than, let us get a particular benchmark. Let us assume that our benchmark is what do you call it? Our benchmark is GFR. This is what the clearance should be. You now check the clearance you are getting in the question. The clearance is more than GFR. It shows that substance is secreted. The clearance is less than GFR. It shows that substance is reabsorbed. What I am getting, I'm supposed to see 20. According to GFR, I'm seeing 15. It shows that substance is reabsorbed. Do you get me? All right. Or if they are equal, it shows that substance, the clearance I get is equal to the GFR they give me in the question. It shows that substance is neither secreted nor reabsorbed. So a benchmark that they will give you, more or less like a standard, is the word GFR. So any clearance you get, you want to correlate it to that standard called GFR. So if the standard is saying that the clearance must be 10, and you now calculate the clearance of this substance, you are now getting 8. You will be like, how come the clearance should be 10? I'm getting 8 here with respect to this substance. It shows that substance you are using is actually reabsorbed because it's less than the GFR. If the standard is saying you should get 10 and you are getting 12 according to the clearance from the plasma, it shows that substance is secreted. The standard is saying get 10, you are getting 12. Who is adding 2? The kidney is adding the remaining 2. You check it, the standard is saying get 10 and you are also getting 10. It shows that this substance is neither secreted nor reabsorbed. If I thought they asked you that, which of the 3 substances you have mentioned can you use to calculate the GFR? Definitely it is the one that is giving me the accurate value or accurate magnitude that is similar to the GFR. It is the one I will use. Anytime I want to calculate that GFR, I will just pick that substance that is neither secreted nor reabsorbed, because it is the one that will give me equal value with the GFR. All right, so that is this formula. You can pick your pen. I want you all to pick your pen now and try to illustrate it the same way we've illustrated it. Please try to do it. Don't say that who you be to tell us to pick pen. Please, I beg you, just pick it and do it. You will appreciate it later. Just start by saying mass that is leaving the plasma, mass leaving the plasma, or mass filtered is equal to mass entering the urine. Just write M, bracket it, put P, equal to M, bracket it, put U. You can be following my prompting. Then you can now say mass is equal to concentration. Write it, conc multiplied by volume. Write it out like that, multiply by volume. Don't write CV because you may start confusing C for clearance. Write conc multiplied by volume. So now come and replace that mass with conc multiplied by volume. You now have concentration multiplied by volume. Bracket it again, put plasma equal to concentration multiplied by volume. Bracket it again, put urine, U. Then put divided by time on both sides. Divided by time, divided by time. So you now have concentration multiplied by volume over time, bracket, put plasma, equal to concentration multiplied by volume over time, bracket, put urine. So if you like, you can say your volume over time in plasma is clearance. Your volume over time in urine is urine flow rate. That's all. That's all you need to know. All this and this one is equal. You don't need it. So that when they start twisting it, your brain will be analyzing it because you understand where the formula is coming from. All right. So that is about the clearance. So remember your reference. That is your GFR. So let us go through some questions and see the way you have a lot of questions to solve later. I'm just going to show you this one question. A clinical trial of a novel drug X is being conducted. Animal studies have shown that this drug is eliminated primarily by the kidney. A healthy volunteer of the body weight 60 kg is recruited and his glomerular filtration rate is 100. So anytime you are reading your question and they give you your GFR, just quickly note it down. GFR is giving 100 mils per minute. Definitely it will be volume over time because it's equivalent to clearance. Okay, in this volunteer, plasma concentration of the substance immediately after intravenous administration is 0.5 milligram per mil. Urinary excretion rate of the substance is found to be 75 milligram per minute. Now, if you look at it, anytime you are reading the question like this, just look at it. You look at the unit. You've already written your formula down. It now be like milligram over minute. This is more or less like that mass over time. The main formula. This mass over time. Can you see mass over time where my cursor is here? That's just what they are giving you here, like the main thing. So if at all you want to be doing any calculation here now, from this one in the urine now, excretion in the urine, if you are now, where will I put it? You just put this at 75 milligram per minute. This is where it's going to be. Just one value. You don't need to multiply it with anything. If at all you now want to be calculating anything, you can see this is mass over time, plasma equal to mass over time for the urine. That's 75 milligram per minute in the urine they give you will be here. And you expect it to be equal to that of the what? Of the plasma. Very easy and straightforward. So if at all they now ask you that, okay, this is the concentration of that same substance in the plasma, what is now going to be the clearance of that same substance? Don't forget that they've given you 75 milligram per minute for the urine. You just write your concentration multiplied by volume over time, which is the clearance, equal to that 75. Because it's the same thing. It's that 75 milligram per minute. We broke down to this formula. So you don't need, just equate it there. So anyhow the question comes, you will just realize that you are getting the answer because you know what the foundational knowledge is, where that formula is coming from. But when you cram the formula here, you will not be able to solve some questions. In fact, so many questions you won't be able to solve for USMLE. You won't be, just be like, I don't know. All right. So when another medication, drug Y, is now co-administered, the urinary excretion rate of the drug S is now 50. For the drug S, when nothing was actually given, urinary excretion rate was 75. When they co-administer S with Y, the urinary excretion rate now dropped to 50. What do you think happened? Definitely that drug Y is doing something to the drug S. It's reducing the, what do we call it? It's reducing more or less like the rate or the quantity of the drug X that is eventually lost in the urine. You can look at it like that. The way it's now reducing it, you do not know yet until you read the option and see which one they are going for. All you can see here is that when the drug Y is co-administered, what was filtered before now reduced. What they were seeing in urine, I wanted to say, has now reduced. That's all you can see. So now see which of the following effect of drug Y on the pharmacokinetic of drug S best explain findings in the study. All right, so what can you see that is best explained? Look at option A, decreased renal tubular reabsorption. Please let us mute all our mics. If this is going to be the answer, do you think the thing will reduce from 75 to 50 with reduced renal tubular reabsorption?
No.
It will rather go
No.
higher. It will even go
Yeah.
higher. Exactly. Yeah. Look at increased glomerular filtration. Increased glomerular filtration. That's what they are putting here. You just put this one aside for now, because that is when you are looking at the clearance. Do you get me? So you don't need to. So look, let's mute our mics. Look at this option B so that I don't waste your time. Decrease renal tubular secretion. So do you think this one is going to reduce the quantity you are seeing in the urine?
Yeah.
Yes. So that's why the answer is B. All right. So that's just by the way. Now, this is glomerular filtration rate now. That standard I mentioned. How do we even know the standard? The standard is called GFR that you are going to be correlating everything with. How do you even determine it? How do we calculate it? Let me clean all this my page here. All right, sorry, 1 minute. That standard, how do you get it? So that when you read the question, you already know which parameter you will be using to calculate that standard. So now there are two ways of getting the standard. The first way is by what we call inulin. Inulin, you want to forget inulin because of what? Even if you have inulin, you don't forget inulin here. Like, you remember it, stick to it and be like inulin. It is the molecule that will give you accurate value for the GFR. Because this inulin, it is neither secreted nor reabsorbed. When they give it, it is neither secreted nor reabsorbed. So when they calculate the clearance of this inulin using their formula, the formula you derive by yourself, the clearance you get for it is going to be equal to the GFR of that patient without even dropping 0.01. Without dropping any value, it's going to be accurate with it. All right. So what it means is that any patient that comes, you need to be giving the patient inulin to drink. You need to put the inulin inside the patient's blood. Gets into the patient's blood and now be calculating the clearance. So you don't need how many people. So once people now come, you are now going to be giving them something and they like, you don't need that. So we now look for another molecule that can give us also approximate value of GFR, and that molecule is biologically produced in our body, and that molecule is what we call creatinine. Yes, the same creatinine you see in the electrolyte urea and creatinine. So this is now the second substance. So you must never forget this creatinine. Now, what is it about the creatinine you want to take into the exam compared to the inulin? Creatinine will slightly overestimate GFR. What it means is that if the GFR is supposed to be 100, when you calculate the clearance for the creatinine, you are going to be getting something like 120. You will be getting something like 120. Whereas the normal thing, the normal GFR, glomerular filtration rate for that kidney, for that patient, is actually 100. So when you use creatinine, it will slightly overestimate it. This is another question they will ask. They will just say that a substance is given, and okay, they use creatinine to calculate it. Maybe they first of all use inulin, now they are using creatinine. What do you think is likely to be the GFR? So if the inulin is giving you value of 100, so creatinine will be giving you something that look like 120. If the question says that they use creatinine to calculate it, creatinine is giving you 120, If at all you use inulin, what do you think the value is likely going to be? You will be going a bit lower, like something like 100. So this is a concept you must never forget. Now, because this creatinine is now produced from our body, are there any factors that can make someone to produce creatinine? Yes. Someone that has a very large body mass is going to produce a lot of creatinine. So you are likely to be seeing their own GFR a bit also higher than what it should even be. So never forget the body mass when it comes to creatinine. So serum creatinine do not start rising. And that's another last point I want to make here. Until GFR is reduced by approximately 50%. It is when the GFR has reduced that you start seeing. So all those electrolyte urea and creatinine that you are seeing, most especially for CKD and all manner of renal failure, when you start seeing creatinine going up, then most likely the GFR has dropped. So these are just the point. This formula here, you don't need to cram it. Don't cram any formula here. Just flow with what you already understood. All right. So in the exam, when they give you a substance and they name that substance inulin or creatinine, any clearance you get, you take it as your GFR. Any clearance you get, you take it as your GFR. Any clearance you get, you take it as your GFR. And that is all. So if they give you inulin or creatinine, any clearance you get for them, you take it as your GFR. I want you to look at this question. A study is conducted to standardize laboratory equipment in a hospital network. In one hospital, 2 healthy volunteers undergo testing. Both are found to have a serum creatinine of 1.1. In one hospital, 2 of them. So glomerular filtration rate is estimated using the same equation and reveal the value of 118 ml per minute in one volunteer and 70 in the other. They are using the same thing anyway, and both of them, they have the same creatinine. So if 2 of them actually have the same creatinine, you expect 2 of them to have the same GFR. Do you get me? That's like more or less like an hypothesis. Like I expect them to have GFR. How come the GFR I'm now getting in one is 118 and the other one is very low, 70? So you start thinking towards something like body mass. Maybe one is bigger than the other or something like that. So that is how this area is tested. A difference in which of the following parameter best explain, you'll be thinking towards skeletal muscle mass. All right. Let us solve this 1, 2 together, and you can now start practicing with the remaining 1 or 2. Okay. In an experiment, 3 liters of isotonic saline are infused intravenously into a healthy volunteer after multiple baseline physiology parameters are recorded. Now, the serial blood pressure measurements show an increase in systolic and diastolic blood pressure. Ultrasonography revealed an increase in the left ventricular volume and engorgement of the inferior vena cava. All right, which is trying to tell you that the patient is in failure. The left ventricular volume is increased and inferior vena cava cannot empty into it. It shows that you have a lot of blood in the heart that are finding it difficult to go out. Probably maybe the the heart is not contracting well. Then as a blood level of a peptide hormone have also increased compared to baseline. So this hormone most likely increase which of the following. Now, which hormone do you think they are likely talking about here that is going to be increased in a patient with heart failure? Who remembers that hormone?
Natriuretic peptide.
BNP and AMP. So what do you think BNP and AMP will do? Who remember? They will dilate what?
It will dilate the efferent.
Exactly. They are going to dilate the vessels. So when they dilate the vessel, most especially the the afferent. When they dilate the afferent vessel, blood will rush into the kidney. So there will be increase in what? Intraglomerular pressure. That increase in intraglomerular pressure will now squeeze most of those fluid out. What do you now think is going to do to the GFR?
Increase.
So just say that GFR, glomerular filtration, filter, when you are filtering something, do you get me? Is going to increase. So let me show you something before I go. let me, where is that thing? I shall hope you are seeing my screen. There is something we call it juice squeezer and juice squeezer. Let's look at it. And juice squeezer. Yes, this is the juice squeezer I want you to see. So you imagine you put the juice here, you now put you just place your hand there. The thing might not really squeeze it out. The rate at which it will come out will be very small. When you press it down, the rate at which the juice will squeeze out will be very high. Look at this thing as your GFR. Anything that make the pressure within the glomerulus to rise, the squeezing out, which you call GFR, is going to also rise. So if you go and constrict the efferent and afferent is dilated, blood will rush to the kidney, but they won't be able to go at the same rate. So the blood that will now accumulate within the glomerulus will raise the intraglomerular pressure. This is the pressure you are using to, you are now pressing it down. So what do you think will happen to the GFR? It will rush out. Like the juice will rush out. So look at it like that if you wish. If you think it doesn't make sense, discard it. So that's why the answer here is just B. Okay, I want you to try this question. A 51-year-old man comes to the emergency department with sudden onset, sharp left flank pain, nausea and vomiting. He has had no dysuria or hematuria. The patient has no past medical condition and takes no daily medication. He does not use tobacco, alcohol, or illicit drugs. Temperature is normal. On examination, the patient appears to be in severe pain and cannot find a comfortable position on the bed. You still do not really know what is going on. This is a 51-year-old man. There is no abdominal rigidity or rebound, and no masses are palpable. Cardiopulmonary examination is normal. There is no peripheral edema. Imaging shows 1 centimeter calculus in the left proximal ureter at the level of the L3, the renal pelvis, and proximal ureter are dilated. So you already have an idea of what is going on. There is a blockage in the what? In the ureter. So as the urine is coming from above, that stone will not allow that urine to pass. So this is the kidney. So this is the ureter. So you now put a stone here that is blocking. So as the urine is formed, it can't really go out. So this place will be dilated. So you now see you are also going to have hydronephrosis. So we'll look at the picture. Which of the following is most likely increased in this patient's left kidney? So which kidney is even affected before we go and pick wrong answer? It is actually the left that is affected here. So this is the patient's left kidney. So what do you think has increased here? All right. For you to know the answer, so we are now going to look at this as, permit me to just represent it like this. So this is the Bowman capsule. So permit me to just represent it like this. Let us assume that this is the stone. And this is the glomerulus. All right. So if at all there is a stone here, what do you think is going to end up happening? Do you think this thing is affecting the glomerulus? Do you think the pressure within the glomerulus is increasing? So let's just come and look at it. Look at the Bowman capsule space oncotic pressure. Do you think this is affecting the Bowman capsule space oncotic pressure? Oncotic pressure is talking about the pressure. We'll still look at it. I don't know why I put this question here, but just let's finish it. Oncotic pressure is talking about the pressure that is that is exerted by the protein that is present. So this is just stone. They say is here. Is this increasing the protein inside the Bowman capsule, or is not increasing the protein in the Bowman capsule? Anyone?
It's not.
It's not. What is the relationship between stone and the protein? I don't think they have any relationship. Glomerular filtration. Do you think the rate at which it's going to be filtering here, despite the presence of this stone, will increase?
Should be reduced.
It will even be reduced, so it's not going to increase. Intraglomerular capillary hydrostatic pressure. Do you think this is going to raise any? All right, exactly. So tubular tubular hydrostatic pressure. Do you think this is going to raise the pressure that is here as a result of accumulation of fluid?
Nope.
No.
Who say no? Tubular.
Yeah.
Tubular
Yes.
hydro. Oh,
Yes.
Yes. Because fluid is
Yeah.
accumulating
But
here.
it's the way you pointed it.
Okay. Fluid is accumulating here, right? Inside this tube. True or false?
True.
True. So if true fluid is not flowing out, that fluid that is accumulating will generate what we call tubular hydrostatic pressure. Hydro, fluid. Do you get it? So hydrostatic pressure. Maybe you can even look at it as a result of stasis, if I thought it makes sense. So what about tubular oncotic pressure? Do you think it will affect the tubular oncotic pressure?
No.
So the answer here should definitely be D. So it's going to increase the tubular hydrostatic pressure. So that should be the answer. All right.
So what of C?
What about C?
We've not, I think we look at it. Intraglomerular capillary hydrostatic pressure. So you put a stone here. How does that stone get into the blood and is now increasing intraglomerular hydrostatic pressure there?
I
How
think
does
by
it leave the Bowman space? How does it, and is now in the glomerulus that you are now seeing the effect? You can only be talking about something influencing the glomerulus. Maybe more blood is flowing into the glomerulus or less blood is leaving. Do you get it? Yeah, this is actually something you are seeing in the tubo. All right. So you are still going to solve a lot of questions on this, a lot of questions on. So you will get used to it today. I know I have a lot of questions here, which most of the time I don't allow people to solve, but you will permit me. You will not. It will not make sense to you now that you are solving all those questions, but I am the one that know what I'm trying to achieve, and it is later you will appreciate it. Okay, that Festus was not rushing you on it, on this calculation. All right, so that is for this tubular hydrostatic pressure. Is there any other question here? I want you to pick your answer here. A 58-year-old man comes to the emergency department due to generalized weakness, anorexia, and nausea for the past several weeks. He also reports lower extremity swelling but has had no dyspnea or chest pain. The patient was diagnosed with hypertension several years ago but did not follow up and takes no medications. Blood pressure is 180/200. Pulse is 84. Physical examination shows pitting edema of the bilateral lower extremity. Laboratory study revealed elevated serum creatinine and blood urea nitrogen level. During evaluation of renal dysfunction, total urinary creatinine is measured over a 24-hour period and creatinine clearance is calculated using serum and urine creatinine concentration and urinary volume. Compared to the calculated creatinine clearance, this patient true glomerular filtration rate is most likely to be what? Do you think
20%.
20%.
20% lower.
Less than 20% lower.
Do you all agree that it will be 20% lower?
Yes.
All right. So I agree with whatsoever you agree with. So that is that about this area. So we are done with this area. So let's see the renal blood flow. Now, what happened and the renal blood flow autoregulation, I mean. The same renal blood flow I was trying to, the normal renal blood flow, how is it regulated? It's regulated by myogenic mechanism and tubuloglomerular mechanism. So I don't want you to cram anything here. Don't cram anything here. All I want you to see is that myogenic, we have two parameters. The first one, sorry, that's my tracer. Sorry, 1 minute. Okay. So the first one is blood pressure. The second one is sodium chloride. I just want you to look at this guy, the way they will be influencing. All right. So anytime there is sudden increase in blood pressure, how do we still maintain the pressure with which the perfusion of the kidney occur? Do you get me? Like to still ensure that glomerular filtration rate is still going to remain constant, the renal blood flow. Because if you run now, something happen, You are just like, the pressure just jump up. Do you think renal blood flow and GFR will also increase during that time? No, they don't increase. Two of them will still be constant. How come? What happened? How come they do not increase? Maybe blood pressure just jump up now for this patient. The GFR also show, renal blood flow should increase, GFR should increase within that 10 minutes that the patient experiences it. No, it will remain constant. Why? This is the reason. When that patient experiences that increase in arterial pressure, that blood rush there will be this stretching of the afferent arteriole. Can you see? Afferent arteriole will stretch to accommodate that increase in blood that rush in. So there will be this mechanical activation of vascular smooth muscle, and the next thing they go into is vasoconstriction. So they will first of all have this initial stretching of the afferent arteriole. The next thing you see is vasoconstriction of the afferent arteriole. They will stretch more or less like when you are dealing with what do we call it? What do I want to talk about? Reflex. I wanted to say reflex. Do you get me? So like that sudden increase in the arterial pressure, the vessel will just dilate, and the next thing, that dilation will just cause activation of this vascular smooth muscle, and they just go into constriction back, and that constriction they have will now reduce renal blood flow. So it is a question. They will just give you and just tell you that there is a sudden increase. What do you think will happen to the GFR? What do you think will happen to the renal blood flow and the likes? So in that table question that you are looking at, the renal blood flow will drop from that sudden increase of arterial pressure, I wanted to say. Then there will be, you expect the GFR to reduce, to actually increase in the same proportion, but GFR will rather remain constant. So autoregulation helps maintain a constant renal blood flow and the GFR, because you expect this increase in arterial pressure to increase it. So that sudden increase that will happen will quickly come back to normal. So it will reduce back. That is where this reduced renal blood flow is coming from. So that this renal blood flow will now eventually remain constant. GFR also will remain constant. Okay, that is for myogenic. What is helping it out is this vascular smooth muscle activation. What about the tubuloglomerular? All I want you to see here is that's macula densa. Yes, that macula densa. Sodium chloride, that is, if you have high sodium chloride reaching it, filtrate reaching it, there will also be reduction in the renal blood flow. And the mechanism behind that is paracrine-driven vasoconstriction. Paracrine-driven vasoconstriction of the afferent arteriole. Because don't forget that they are juxtaglomerular apparatus. They are actually closer to themselves. So that macula densa senses sodium chloride. So how do you think high level of sodium chloride is going to reach macula densa? When you are having high GFR. Now, when the GFR is very high, tubular cells, they don't have enough time to reabsorb sodium, to reabsorb glucose, to reabsorb all those stuff. So the quantity of those substances you will now be seeing in the urine, in the filtrate that will reach the distal convoluted tubule will now be very high. Because as they are high, macula densa is shouting, how come they are high? How come the quantity of sodium in the filtrate reaching me is high? And the next thing that proximal convoluted tubular cells are shouting is that the rate at which the thing flow across us here is too high. We couldn't pick all of them. That rate at which it flows through them being high is actually what you call the glomerular filtration rate. So any question you read where the glomerular filtration rate is high is most likely sodium chloride that will be reaching the distal convoluted tubule will also be high. Because those proximal convoluted tubule that should reabsorb, or the reabsorption that should occur, there is no time for them to occur. So the macula densa will now respond to high level of sodium chloride reaching it. That one will interpret it that the pressure inside the blood main blood is very high, it will now reduce the renal blood flow. So you call this tubuloglomerular mechanism. The first one is myogenic at the vessel level. This one is at the tubular level, tubuloglomerular mechanism. All I want you to do is just to have an idea of what is going on, releasing to this area, and you will be fine. Now, what about the effective renal plasma flow? Now, effective, you don't need to cram anything here. There is no cramming here. The only word you need here is this para-aminohippuric acid. If the para-aminohippuric acid will remove your front teeth, just remember PAH. Remember PAH, para-aminohippuric acid. So look at this para-aminohippuric acid. You use it to determine the effective renal plasma flow, or you just call it renal plasma flow. Renal plasma flow. You can look at it like that. The effective one, this para-aminohippuric acid usually is going to underestimate the true renal plasma flow. It will underestimate it slightly. Do you get me? It's going to underestimate it slightly. All right. So anytime we read the question, you want to determine the renal plasma flow, you will be looking for clearance of para-aminohippuric acid. Now relax. In the exam, they will now list some substances for you. You call it, the first one, they will just list in creatinine. They will give you the clearance. They will just mention clearance of creatinine. Creatinine clearance. Permit to just represent it like this. Then para-aminohippuric acid, they will put its clearance. This one is 10. This one is 15. Permit me to show you. That's all what they will give you in the question. They will now ask you, what is the filtration fraction? What is the filtration fraction? Filtration fraction is GFR. I will still show you, divided by renal plasma flow. So what is my GFR now? You will be using 15. What is my, let us turn this one to 30. What is my my renal plasma flow? You will be using clearance of para-aminohippuric acid. So this one will now be 15 over 30. That's my GFR, my filtration fraction will now be 0.5. So they won't mention for you in the exam that this is GFR. The only thing they will mention is the clearance of creatinine. If they like, they can go and put inulin there. So it is the value of the clearance of creatinine you will now be using, or inulin, anyone they give you. If they give you the clearance of para-aminohippuric acid, you will be using the clearance of PAH to determine, you'll be equating it to renal plasma flow. That's all you will be doing in the exam for this. Now, this is the filtration. We have what we call the filtration fraction. GFR divided by the renal plasma flow. We already know how to get our GFR from creatinine or inulin clearance. We know how we are going to get our renal plasma flow from para-aminohippuric acid clearance. That's all. You will now look for the two value and put them into ratio. Whatsoever you get is your filtration fraction. All right, the normal filtration fraction is 20%. Basically, so renal plasma flow is best estimated with para-aminohippuric acid clearance. GFR is best estimated with creatinine clearance. And so that's just by the way. And I've told you about PDA and ACI. So let us just do some practice here. So this is PDA for the afferent, PDA. This is ACI. ACI. Okay. PDA means that prostaglandin will dilate the afferent, angiotensin 2 will constrict the efferent. So if the question says this patient is placed on NSAID, if you place this patient on NSAID, NSAID will inhibit the production of prostaglandin. Therefore, you will be having constriction of the afferent. So constriction of the afferent, that's what you are going to be having. So if you are having constriction of the afferent, what do you think is going to happen to renal blood flow? Anyone?
Decrease.
So renal blood flow, I told you anything that constricts any of these vessels will reduce the renal blood flow. So renal blood flow will reduce. What do you think will happen to the renal plasma flow? Renal plasma flow. Renal blood flow and renal plasma, you can equate them. One is blood, the other one is plasma. So renal plasma flow also will what? Will
Decrease.
reduce. So what do you think will happen to the GFR? You've constricted
Reduce.
this one. Do you think enough blood will come to the glomerulus?
No.
No. So your GFR is also going to reduce. That's all. Do you get it now? Your GFR is also going to reduce. So if GFR is reducing, renal plasma flow is also reducing. What do you think will happen to your filtration fraction?
Reduce.
Thank you for saying that. Renal plasma flow. So this one reduce divided by this one reduce. This one is likely to remain constant.
Okay.
Because two of them are reducing. So this one will remain constant. Should actually remain constant. Do you get me? Had it been just one of them that is changing, so then you will see the fraction actually changing. All right. So that is for the NSAID. Let us look at the question says the patient is placed on lisinopril. Which drug is lisinopril? ACA high. Okay. So look at ACA high here now. ACA high. You place the patient on ACA high. What do you think ACA high will do? It's going to cause what?
Dilation.
Dilate the
It's going-
efferent.
Exactly. Because angiotensin should constrain, angiotensin 2 should constrain the efferent. So if the level of angiotensin 2 drops, so you will be having dilation. So there will be dilation of the efferent here. Do you get it? So if there is dilation of the efferent, what do you think will happen to the renal blood flow?
Increase.
The renal blood flow will increase. What do you think will happen to the renal plasma flow?
It will also
It will
increase.
also increase. What do you now think will happen to the GFR?
Increase.
Now relax.
No.
Relax there. Blood is nothing has happened to this one. Blood is coming here, but this vessel that is taking blood away has dilated. Do you think blood will be staying here?
No.
Blood is not going to stay there. So if blood is not staying here, what do you think will happen to the intraglomerular pressure?
It will reduce.
So if the intraglomerular pressure is exactly, if it's reducing, what do you think will happen to the GFR? What do you think will happen to the GFR? It will also reduce. So now, what do you think will happen to your filtration fraction?
It's reduced.
No, don't just say reducing now.
No.
So this one has reduced. Wait, this one has reduced, and this. Why are you changing your answer? I just want you to put them in ratio. That's all I need from you.
Okay.
This one has reduced, and this one has increased. What do you think is going to happen to the fraction?
Reduce.
Markedly reduce.
Yeah.
Can you see? It's going to reduce.
Yeah.
And this is the mechanism behind you giving a patient with diabetes lisinopril. I will still show you later. I don't want to bring it in here, or let me just, because it's actually important for you to note it. Let me quickly, because this small box here, I think that's what I was trying to show you there. So now what happens in diabetes is this. What happens in diabetes is because the blood sugar is high, the renal threshold is already exceeded and the likes. So what happens is that, what happens is that anytime the sugar here, let me say this is the proximal convoluted tubule, anytime the sugar here is going to be reabsorbed, sodium will also be reabsorbed together with it. So if you have a lot of sugar here that are filtered, a lot of sodium will also be reabsorbed together with it. So what now happens is this. When this filtrate eventually gets to distal convoluted tubule, macula densa will now be receiving a filtrate that is very low in sodium. Macula densa will now think that the sodium inside the main blood is actually low because it's sensing lower than expected. All because the reabsorption of all those glucose has caused most of the sodium to also be reabsorbed. Sodium glucose co-transporter, you remember? So as those glucose are reabsorbed, sodium are also reabsorbed together with it. All right, with them. So the sodium that will eventually be reaching the distal convoluted tubule, is actually very low, very, very low. The sodium that distal convoluted tubule will be receiving will be very low. So macula densa there will now become activated. It's now going to send signal to the juxta glomerular cell that sodium in the blood is low, and juxta glomerular will now release renin. That renin, is going to convert angiotensinogen to angiotensin 1. Angiotensin converting enzyme will come in and shall produce angiotensin 2. That angiotensin 2 will now come here and now cause vasoconstriction. So the end result of that diabetes in this patient is this vasoconstriction here. So this place is narrowed from that process. So that narrow now means that when blood is coming in, blood will now be rushing into the nephron and be staying in the glomerulus. They won't be able to go out. If they are not going out, that means is that the intraglomerular pressure will rise. If intraglomerular pressure rise, a lot of filtration will now occur. The patient will just be filtrating, like GFR will rise. That GFR is going to rise very, very high. All right, it has risen. There are some cells here, you call them mesangial cells. They are not used to high pressure. That constant exposure to pressure irritates them. They start proliferating. When you sit down on a spot for 1 year, I'm very sure if you check your bum, it will be scarred. That is what happened. This patient has diabetes and constantly the intraglomerular pressure is high. So the basement membrane will start develop some thickening. You call it basement membrane thickening. Here, because of increase in pressure they are constantly exposed to, you start having thickening here. Mesangial cells, they start proliferating. You call it mesangial hyperplasia. And they now bring this patient to you. And you look at that patient with mercy. And you are like, this kidney, I want to save you. How are you going to save this kidney? You say that if I allow this process to continue, after a while, the kidney will not filtrate anything again, because this thickening and the mesangial hyperplasia is going to block filtration after a while. And that moment, the GFR is going to start dropping. Don't forget initial hyperfiltration the patient has. If that thing continue and you do not tame it, after a while, thickening, mesangial hyperplasia, basement membrane thickening will now obliterate everything. And the next thing you will see is that this patient can no longer produce urine. So you now look at that. You have already seen the end from the beginning. You are a god there. So you now say, okay, the origin of this problem is this efferent arterial vasoconstriction. You now say, and I will give you a drug. And that drug is going to open up this area so that the pressure will no longer accumulate here again, will not build up here again. So with that thing, when you give this patient like Sinopre, ACE high will open up it will open up efferent arterial. This pressure will no longer occur as such again. It won't occur as such again. So if the pressure is no more building up here, what happens is that intraglomerular pressure has dropped. What happens is that GFR also will drop. And the patient is now asking you, doctor, but GFR is also dropping with this your drug. And you say that GFR is also going to drop if this thing occur. Are you not bringing the end to the beginning like this? You now say, no, I'm not bringing the end to the beginning. You are dropping the pressure here so that the pressure will not drop later. So that the GFR will not drop later. When you drop the pressure here, GFR will also drop. So indirectly, you are dropping the GFR so that the GFR will not drop pathologically later. That is what your drug is doing. Now, Is it that the drug lisinopril is now preventing the patient from coming down with diabetic nephropathy? No, it's not preventing it, it's just prolonging it. That drug, if the patient is supposed to come down with diabetic nephropathy in the next 10 years, it might take the patient 40 years before the patient will come down with diabetic nephropathy. It might take the patient 40 even to 50 years before the patient will. It's not that maybe it's like preventing it from happening, like, even though we call it renal protective, it's not. The diabetes is still there, it's a chronic condition. But if this patient is supposed to develop it in the next with that hyperfiltration and the like, with all this messenger thickening, basement membrane thickening, messenger hyperplasia going on, they won't occur in the next 5 years. They won't occur in the next 7 years. It won't occur. The patient will still be fine. But in the next maybe 40 years, 30 years, when the patient is even almost dying, that is when the patient might now or may not even develop it at all. But it doesn't mean that the drug eliminates it. It's not eliminated. So that is what is happening here. So when you are reading that question and they are telling you that this is a diabetic patient, you already have an understanding of how the drug is working its wonder. So this drug, like lisinopril or any other ACI, they are a must-use drug for any patient that is actually diabetic. It is a renal protective drug. Renal protective. It prolongs the time the patient would develop diabetic nephropathy. All right, so that is that. So I want you, these are the stuff we are going to do now. We'll look at this. But there is an explanation I need to give you here. Now, the explanation here is that it is only in dehydration or anything that is going to cause dehydration. Dehydration affects renal plasma flow more than the way it's going to affect the GFR. So when a patient is dehydrated, blood that will be going to the kidney will also drop. You say the renal plasma flow has dropped. If the renal plasma flow has dropped, then you are also going to be having something like reduction in the in the GFR. Definitely, enough blood is not going to the kidney. Enough blood will not really be filtered. GFR will reduce and the likes. So if the GFR is also reducing, when you now look for the the filtration fraction. So the filtration fraction you are going to be getting is going to actually be high because GFR is high up, is on top, is the numerator. The renal plasma flow is the denominator, and the denominator is dropping more than the numerator. So the fraction will now look increase. So I put an arrow here because this is the only one that you are seeing double arrow that may confuse you. All right. So I think that is all about this area. Afferent arterial constriction. I want you to pick before you ask your question, I want you to pick your pen and paper and now relate with this. Afferent arterial constriction. I will be asking you, everybody, what do you think afferent arterial constriction will do to the renal blood flow? I say renal blood flow. It will reduce. Yeah, if the renal blood flow is reducing, it will decrease. So if the renal blood flow, what do you think will happen to the renal plasma flow? So what do you think will happen to the intraglomerular pressure?
To increase.
Intraglomerular pressure.
Oh, to decrease.
Decrease. So
It will decrease.
if the
No, it will
intraglomerular
decrease.
pressure is decreasing, what do you think will happen to the GFR?
Reduce.
Reduce. So you already know all these things. So when you put two of them over themselves, what do you think will happen to the filtration fraction?
Okay.
Exactly.
unaffected.
It just be constant. So now let's look at the efferent arterial constriction. What do you think will happen to the renal blood flow? It will reduce. What do you think will happen to the renal plasma flow? It will also reduce. Once there is constriction, once something happens to the vessel. So what do you think will happen to the intraglomerular pressure?
Increase.
It will increase because constriction is at the efferent level. Afferent is still bringing in the blood. So it will increase. So what do you think will happen to the GFR? The GFR will now rise. So now, what do you think will happen to the filtration fraction? It will increase. Can you see it? So what about if we are increasing plasma protein in the blood? What do you think that plasma protein will do? They draw fluid to themselves. Do you think they will favor filtration or they will not favor filtration?
They'll favor themselves.
They will.
They will not favor
It will not
filtration
favor
because they are
filtration.
drawing fluid to themselves.
Themselves.
Do you get me? So these are the plasma protein in the glomerulus. They will rather hold onto those fluids and prevent them from being filtered than to allow them to be filtered. So,
But the intraglomerular pressure will be increasing.
it's going to be increasing, but they are not going to favor filtration. Do you get me?
Yes.
Hello, do you get my point, everybody?
Yes.
Yes.
All right. The way you are talking is like everyone just wants to go and sleep. It's all right.
No, please.
You draw it, sir.
All right. So just get the point. So they will draw fluid to themselves. So GFR is going to reduce. So now, if they give you a question of multiple myeloma, a patient with multiple myeloma, what do you think is going to happen to GFR with a patient with multiple myeloma? It will reduce.
It will reduce.
Exactly. Now, what do you think will happen to a patient, to the GFR with a patient with nephrotic syndrome? What do you think will happen to the GFR in a patient with nephrotic syndrome?
Increase.
Because that one is losing protein into the tube. Those protein will be drawing fluid to themselves. So they will not be favoring what? They will be favoring filtration. So the GFR is going to increase in nephrotic syndrome. Do you get me? All right. What about this surgeon that just tied the suture the ureter? What do you think is going to happen to the intratubular hydrostatic pressure here? Increase. Because fluid is just filtrates will be accumulated and will not be able to go forward. It will be increasing. Do you think that one will favor filtration or oppose filtration?
No, it will.
It will favor
It will. Therefore, the
filtration.
GFR will what? Will drop.
Increase.
So now you have an idea. Now, a patient with BPH, what do you think will happen to the GFR in a patient with BPH?
It will reduce.
It will reduce. But do you think that won't have anything to do with the blood vessel? Renal plasma flow?
No.
You won't think about renal plasma flow there. So when you are looking for your filtration fraction, you already know whether it's going to reduce or it's going to increase based on, because your renal plasma flow will just remain constant. If anything is affecting the tubule, let it stay within the tubule. Do you get me? If anything is affecting the blood vessel, that one can affect filtration. Do you get me? Because GFR is pegged on glomerular filtration pressure. Do you get me? So the more the glomerular filtration pressure, the more the GFR. The lower the glomerular filtration pressure, the lower the GFR. And the glomerular filtration pressure can also change depending on which vessel is dilating, which one is constricting. All right. So that is that about this area. So permit me.
That's my question now.
Yeah, Dr. Nancy.
Okay. In regards to treating a diabetic patient with lisinopril, is it diabetic patient with high blood pressure or just any diabetic patient?
Now, that one the damage you see, you call them, what do you call it? Microvascular damage. You see, is going to, I don't know how to even increase it, when the patient is having high blood pressure and is also having diabetes. Double bullet is too much. Do you get me? It's going to be too much. You imagine what will now happen to the glomerular filtration pressure here. I mean, intraglomerular pressure here. If there is also increased blood pressure on top of the damage that the glucose alone is now causing. That is the reason why when you see the BP just increase like it's high last one, anyhow, just make sure that the first antihypertensive drug you are even going to be thinking about is also going to be what? It's also going to be lisinopril. So most of the time, what people do, what they do is that if there is no established diabetic nephropathy and the patient is not hypertensive, they will just leave the patient and control the sugar. They don't even give the patient the lisinopril. They will just control the sugar. There is no microalbuminuria, the patient is not hypertensive. Just control the sugar. The patient should be okay. Once there is microalbuminuria and the patient is diabetic, I never mention what do you call it? I never mention anything like hypertension yet. The patient is diabetic, there is microalbuminuria, then you place the patient on lisinopril. Now, that is one. There is no microalbuminuria. The patient is diabetic and the patient is also hypertensive. You also place on lisinopril. So lisinopril in the first instance is actually reducing the rate at which the diabetic nephropathy is progressing. Lisinopril in the second instance is used to reduce the double bullet on the kidney. So it's going to treat the hypertension. It's also going to help the patient with, preventing the patient from coming down with all these complications on time. Most especially the diabetic nephropathy. So when you are reading the question, and this is just a diabetic patient, there is no microalbuminuria, the patient does not have IBP, there is no need to give the patient, you just control the sugar. That's the only thing you want to do. If there is diabetic and the patient is having BP, IBP, place on lisinopril. One of the drugs that must be there as the antihypertensive is lisinopril. Now, if there is diabetes and the patient is having microalbuminuria, the patient does not have IBP, make sure you place the patient also on lisinopril. All right. So that's just by the way. I hope I don't know if I thought I answered your.
Very, very clear. Thank
How
you.
is the
Dr.
lisinopril
Festus,
tackling the microalbuminuria?
How is it what?
How is it sorting the
It's not sorting the
microalbuminuria?
microalbuminuria. It's not. It's not solving the. It's only prolonging the rate at which the kidney will fail completely. Do you get me? Because the patient already, once you see microalbuminuria, the patient already have diabetic nephropathy. There is already microalbuminuria there. So there is established diabetic nephropathy with that. And the next thing is that how can I reduce the progression? You now reduce the progression and be like, the rate at which this kidney will fail completely. Let me place the patient on this ACE high. You now place the patient on ACE high. And I thank you for that question, because that's actually the three categories of questions you will be seeing in the exam. With respect to, do I want to give this patient ACI or don't I want to give the patient ACI? When you look at the question, you just be like, this is a pure diabetes. There is nothing like high blood pressure. And you check, they will give you the microalbumin level, the albumin level in the urine. Once it's like less than 30 or so, if I'm not mistaken, that is not microalbuminuria. Microalbuminuria is like 30 to 300, if I'm not mistaken. So if they will now give you the albumin level or protein level inside the urine and they will say it's 20, you just say this is not microalbuminuria. The only thing is just to control the sugar. So once they tell you that the albumin level inside this thing is like 60, there is established microalbuminuria, then you want to place the patient on ACA high. That is that. So if there is no microalbuminuria, you don't need to give the ACA high unless the patient is hypertensive. Okay, so now I want you to this is likely going to be the last thing I will do today, likely, because I want you to solve all those questions, all of them. Permit me, if you like, just hate me for that. Just solve
Dr.
them.
Festus, please, I didn't understand the dynamics between the BPH and GFR.
Okay, BPH is blocking the bladder, right? Bladder neck, right? Are you with me?
Yes, sir.
Okay, BPH is blocking the bladder neck, right? Oh, you are not there.
Yes, it is.
Yes.
All right. Yes. Okay. I want to be prompting you for you to get to
Answer him, yeah.
Yeah. Oh, lovely. So now the urine is accumulating. Now the patient is already having reflux. Most of these urine, they can't go forward. The patient is even in retention. So now what do you think is going to, this thing eventually lead to hydronephrosis? Like the patient is already having renal impairment, hydronephrosis, because of the obstruction the patient is constantly having. What do you think during that time of attack? What do you think is going to happen to the intratubular hydrostatic pressure or tubular hydrostatic pressure?
It will increase.
It will increase. Now, tubular hydrostatic pressure is there, preventing the filtration. If the level is high, if the value is high, do you think more fluid will be able to come into the tube?
No.
No. Where will they even enter? The one that came the other time is still there. They are shouting, we are still here, we've not gone anywhere. And another one wants to come in. Where will they stay? So there will be reduced GFR. Do you get
Thank
it?
you very much. I got it,
So,
yes.
now, I want you to solve these questions. You will solve all of them for me, please.
Dr. Festus. Dr. Festus.
Yes? I can hear you.
Yes, I didn't understand. Yes, I didn't understand how increased plasma protein concentration, the relation between it and GFR, how it decreases.
Okay.
I think I'm getting confused.
Look at this place. That will be the last question for now. Look at this place. Put plasma protein here. What they do, they hold on to a fluid that want to escape. Look at yourself being the police. You are the plasma protein. You are holding on to one arm rubber. You hold on to it. You are even many there. Plasma protein, there are many here. 5 of you. You are holding on to it. Do you think it will be able to go easily?
No.
No. So if it can't go easily, show that the GFR will drop. Glomerular filtration rate will reduce. Once anything that increase, once the plasma protein rises, then there will be a reduction in GFR. So if 5 people are supposed to hold on to that thief, that number, that 5 policemen now drop to 1. Do you think the thief can easily escape or not?
Yes.
It
No.
can easily escape because 5 people were supposed to hold. 1 person is holding. Do you get me? So when the plasma protein is actually reducing, fluid can easily be filtered because that thing that should hold them back is already low. You call it oncotic.
Okay.
Like they give rise to oncotic pressure. Do you get it?
Yes.
All right. Now, all of you, I want you to take these questions one by one. If at all whatsoever we are doing does not make sense to you, just log out and no one should send message to me. All right. Look at this. A 48-year-old woman is evaluated for postcoital bleeding and vaginal discharge. Pelvic examination shows a friable mass at the cervix that bleeds easily untouched. Cervical biopsy confirms invasive squamous cell cancer confined to the cervix and uterus. Lymph node metastases are not seen. A radical hysterectomy is performed, during which the right ureter is accidentally injured but then repaired. Imaging study performed after the surgery show a partially obstructed right ureter with mild dilation of the proximal collecting system. Which of the following changes are most likely to be seen here? So what there to be seen in the right kidney? I will show you 2 ways by which this question can be addressed. Now, this question is saying right kidney. Right kidney is the one that is affected. On that right kidney, what do you think will happen to the GFR? They have sutured the ureter. There is a partial obstruction to it. Do you think urine will flow easily through it?
No.
It will decrease.
No.
Exactly. So GFR
No.
will decrease, right?
Yes.
Exactly.
Yes.
Now, what do you think will happen to the renal plasma flow?
To still reduce.
It would
It
still
will
reduce
reduce.
again. Is this one reducing the renal plasma flow?
No.
How is
No.
it?
Okay,
No,
it's
it's
not
not.
affecting it. It's not
It's not affected.
How is it affecting the vessel around it? How is it affecting the afferent and the efferent? All right. So if it doesn't have anything to do with the renal plasma flow, GFR has already reduced. What do you think will happen to the filtration fraction?
Reduce.
Now, if the question they ask you is about which of the following changes are most likely to be seen in these patients, they now give you GFR. You are likely going to see the GFR normal because the other kidney will compensate. So you will say no change.
Oh.
You will just be picking no change, no change, no change. If nothing happened to the GFR, you don't expect anything to happen to the filtration fraction for both kidney. That's how you will look at it. The net results. Do you get me?
Can you
So
start
now,
again,
if
Doc?
they want
Yes.
you, what I notice is that in the exam, they will lateralize it and mention that, okay, in the right kidney, in the left kidney, what do you expect? So please watch out for this. I want you to look at this question.
But sir, the answer is E here. I thought you said the GFR will be constant.
Is in the right kidney, the one that is affected, the one that
This
is
in the right
injured.
kidney. I said two questions for you there.
Dr. Festus, please, can you go through that again?
Please, can you go through it again?
All right. So this is the last time I will go through something again. The next time you will go and be listening to it. So let us all open our ears very well. I'm not saying you are not opening your ears, but you can open it wider than that.
All right, sir.
Shall I explain? All right. Okay. What we are saying here is this. In the exam, you need to watch out. You know, this is just one question. Now, what is making you to think the way you thought is because the question is saying in that same kidney that is affected. Another way they can say this question is in this patient, not in the right kidney. So in the right kidney, something is going on that is not normal. Left kidney normally compensates. The other kidney will compensate. So if the right one is injured, second one will compensate. How come someone that has two kidney can easily give out one and the GFR is not supposed to be affected? Why? Because the other one will do the work of the two. So if the question is talking about in this patient, everything is no change, no change. Because the other one that is not injured will cover up. But in the right kidney, the one that is affected, you will definitely see the change of what has happened there. Do you get it now?
Yes.
All right.
Yeah.
I want you to pick your answer here for me, please. An experimental substance is infused intravenously at a constant rate into a healthy volunteer. The substance is known to selectively constrict the efferent arteriole. You may need to be playing the Ludo on your paper there so that you won't say wrong thing. So whichever answer you choose is what I will flow with you with. The rate of infusion is closely controlled during the experiment to allow for only mild constriction of the efferent arteriole. Which of the following changes in GFR and filtration fraction is most likely to occur during the infusion of this substance? So what do you think? What do you think that substance is doing to the kidney, to the nephron? It's constricting the what?
It's constricting
The
efferent.
efferent.
So if the efferent is constricted, what do you think will happen to the intraglomerular pressure?
It
Increase.
will be
Increase. It will increase.
So if the intraglomerular pressure has increased, what do you think will happen to the GFR?
It will increase.
So our
increase.
answer is between C and D.
Yes.
So now, what do you now think will happen to the renal plasma flow?
It will reduce.
It will.
It
will
is normal or
It will
Who say
reduce.
normal?
It's
Who mentioned
reduced.
normal? Name someone
It
that
will
will be picking
decrease.
people. Who mentioned normal? So because there is constriction of the efferent,
Constriction,
any
it
of
will
those
reduce.
arterial, once there is constriction in any one of them, there will be reduction in the renal plasma flow. Don't forget that. If there is dilation in any one of them, there will be increase in renal plasma flow. Do you get it? All right. So now there is constriction. What do you think will happen to the renal plasma flow?
reduce.
Reduce. Now, what do you think will now happen to the
Reduce.
filtration fraction?
It will increase.
It will increase. So what's the answer?
Increase.
D.
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 D for the.
All right. Oh, wow. You guys got it. I want you to get all your parameters from this question now. As I will read it and you calculate it and get your answer. Please try to do it. I am prostrating here. Please do it. You see, someone laugh and be like, "Wakpembe." You see, I would do Shingman. Physiologist. are investigating renal autoregulatory mechanisms in an animal species that closely mimic human physiology. During one of their experiments, renal blood flow and glomerular filtration rate are measured in an
Anesthetized animal.
Okay, before you remove your front teeth, let's help you out. Okay, animal. In response to changes in mean arterial pressure, the data they obtain is shown on the graph. Assuming a hematocrit of there is a particular formula I left out. Thank God.
Yeah, minus hematocrit.
Yeah, please, I want you to write all the parameters out. Assuming a hematocrit of 0.5, what is the best estimate of the filtration fraction when the mean arterial pressure is 120? So I want you to note down hematocrit, note down what they are asking you to calculate filtration fraction, and note down the mean arterial pressure at the mean arterial pressure of 120. So now, before you answer that question, there is a formula you need to note here, and that is sorry, please don't be annoyed, and that is the relationship between renal plasma flow and renal blood flow. So renal blood flow is equal to renal plasma flow divided by 1 minus hematocrit. All I want you to do is to write this formula out. After applying it once or twice, you will remember. Please write it down, everybody, and try to use it for your calculation. Okay, so this is what you will now come back to this question and answer this. All right, so I need to show you a graph. Filtration fraction. No, we've done this. Filtration fraction. So now, this is what you want to solve. Everybody, calculate. You only have 1 minute, though. And for those that are not solving anything, we praise you. What's our final answer?
0.2.
0.2.
0.2.
Who doesn't get 0.2? Who doesn't get 0.2? All of us girls is this is so beautiful. That's very. But is there anyone that doesn't get 0.2? Dr. Assumpta, but you didn't talk. It's only your thumb we are seeing. All right. I think that question is quite straightforward enough. Well, let's look at it. So the question they've already given us at what BP did they say we should calculate?
120.
120. So let's assume that our 120 is here. So what do you think is the GFR at this 120, Dr. Assumpta? Dr. Assumpta, are you there?
Maybe 0.2.
Yes.
Yeah.
It has to
What is
be
the GFR?
0 point. It's a
GFR
bit,
at
it's around
120
0.1.
is 0.1. So we've already gotten
Trace
one
it
of our
back to
parameters.
0.1.
Yeah, we've already gotten one of our parameters, right? So
Yes.
now, what is the second parameter we need to
The renal blood flow.
renal? We don't need renal blood
Plasma
flow.
flow.
Renal what?
Plasma flow.
Renal
Plasma
flow. So we do not have our renal plasma, but they've already given us renal blood flow. You are not going to use that. So what is your renal blood flow, Dr. Asanta? Just trace it here. Trace it up. What is your renal blood flow? Trace it down here.
1.0.
1.0. So we already have our renal. So use the formula. What's the hematocrit they gave you in the question?
0.50. Abby?
0.5 is
0.5.
must you add that last zero to it? So 0.5. Now use that formula and calculate your what do we call
Like
it?
the
plasma
that's
flow.
it. Renal plasma flow or renal blood flow. Oh
They've
no,
already
renal
given
blood
you
flow is
renal
already
blood
there
flow
now. Then cross multiply you now. Okay.
So what is
Please,
the
I
final
don't
answer?
know math. I would do it small. I don't know math.
There is nothing small there, Dr. Asanta. Let me show you. What is small there now in what we just talked about?
Please write it on your screen.
I'm writing it down so I can do it like that.
So our renal blood flow is 1.0. Renal plasma flow, we don't know it. Then 1 minus 0.5. What is? So this is 1 equal to renal plasma flow.
Yeah, 0.2.
There's no yard there. There's no yard there. If we say you should calculate it, you say you need to do it small.
I
Renal
wrote it.
plasma flow is equal to 0.5. All right, so that's our answer, Abby. I mean, our renal plasma flow. So now, Dr. Asanta, what is your filtration fraction?
You will now put it in the main formula. Filtration fraction is equals to renal plasma flow over GFR over renal plasma flow. Then you put it and calculate.
And what is the answer? What are you putting?
What we've got to now 0.5.
No, it's 0.1 divided by 0.5.
0.5.
So
yes.
please press your phone for it. What is your answer?
0.2.
So that's actually how those geniuses got their 0.2. Do you get it? All right. So that's that. So let me check if they got it. And that's very correct. So that's that. Very easy and straightforward. So I want you to try this, the next one. Physiologists are studying the forces governing glomerular ultrafiltration using a single nephron in an intact kidney of an experimental animal. Hydrostatic pressure in the glomerular, capillary, and Bowman space is measured using micropipette transducer. Colloid osmotic pressure in the glomerular capillary is estimated using the difference in the plasma protein concentration in the afferent and the efferent. The glomerular surface is assumed to be functionally intact with negligible filtration of plasma protein into the Bowman space. From the data obtained, net filtration pressure is calculated at 10 millimeter of mercury. A substance is instilled into the renal artery and measurements are repeated. The net filtration pressure after the intervention is 20. When they put the substance, what do you notice about the net filtration pressure? It has what?
It
Increase.
Now, so which of the following substances was most likely used? Oya, pick your answer.
Then that dilates the afferent now.
Now, wait before you. So
E, angiotensin 2 agonist.
Yeah, anything that dilates the afferent or dilates the efferent.
Yes.
which answer are you going for? Sorry.
C.
Eh?
C.
C. I'm hearing
No.
E. If you are saying C, C,
E for
E, C, E.
Okay.
I was hearing E. Which one? Is it C or E?
C.
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 Thank you for the person that mentioned cat. Thank you. So you are going for angiotensin 2 agonist because that one will constrict the what? Efferent, right?
Efferent.
So more blood will go into the glomerulus. I mean, blood will go into the glomerular and won't be able to leave, right?
Yes.
So there will be increase in what? Intraglomerular pressure, right?
Yes.
So and there will now be increase in net
And
filtration.
filtration rate.
Exactly. I want you to pick your answer here for me, please. 70-year-old man comes to the office for follow-up of hypertension. He has been taking amlodipine, but his recent home blood pressure reading have been elevated. The patient has a long smoking history and despite many attempts at quitting, continues to smoke cigarettes. Blood pressure is 140/90 and pulse is 76. Examination shows a bruise on auscultation of the abdomen. Further evaluation reveals bilateral renal artery stenosis. After initial discussion, the patient is started on daily lisinopril therapy. The patient is advised to return to the kidney in a few days. They now say that the close follow-up is recommended due to which of the following anticipated effects of this patient kidney function. What do you think lisinopril will do to this patient? Anybody?
It will dilate
The efferent
The efferent.
There will be no
efferent.
change. There will be no change in this patient with bilateral renal artery stenosis.
All right. That's actually a very good point. Do you get me? But the drug that they are giving to this patient already has established is bilateral. So the renal function is already impaired. Do you get me? When you give that drug, it will also work. That is magic on the two of them. So something will happen. What do you think will happen to the renal perfusion with this lisinopril?
increase.
Decrease. This will decrease.
Decrease.
Renal perfusion will decrease.
No.
It will increase.
What will the lisinopril do to the body, to the vessel normally?
It will dilate.
That's so
Now, what
dilate.
do you think is going to happen?
Dilation of the efferents.
Increase.
Yeah. So what do you think is going to happen to the intraglomerular pressure?
It will reduce.
Reduce.
It's going to
It will
reduce, right?
reduce.
Yes.
Yes.
Do you all agree that intraglomerular pressure is going to reduce?
Yes.
Yes.
Okay.
Yes.
All right. That's very fine. So what do you think is going to happen to the filtration fraction?
Reduce.
So what is happening to the GFR, everybody?
It's decreasing.
GFR will reduce.
GFR is reducing.
Reduce.
So what do you
To
think
reduce.
is going to happen to the renal plasma flow?
Increase.
No, it will increase.
Increase.
So what do you think is going to happen to the filtration fraction?
It will decrease.
How is it decrease? It's going to decrease, right? Yeah, that makes sense. Just put your fraction into place. It's going to decrease. Is it not going to decrease?
It will decrease.
Mathematics is
GFR is decreased.
It will because the
they
numerator.
won't stay in mathematics class. They won't stay there.
The filtration fraction will reduce because the
Wait.
numerator.
Oh yeah, let's do it. So the glomerular pressure. What do you say is going to happen to that, right?
It will reduce.
So what do you think is going to happen to the GFR?
To reduce.
The answer is C.
It will also reduce. It should reduce actually. Let me clean this.
Yes, that's reducing the filtration fraction. Then the renal
So what do you think is
perfusion will
going to happen
increase.
to the renal plasma flow?
It will increase.
So what do you think will happen to
Dilated.
the what's the next thing? Filtration fraction?
It will decrease.
Because the
Reduce.
denominator is already higher, it will reduce.
Yes.
So now
Yes.
what's your answer now?
Yes.
C.
C.
Okay.
Remember the bilateral stenosis that I said?
Not right now.
No.
No. I don't agree with this.
No.
The answer should actually be C until proven. I can be wrong, but when you are giving the lisinopril, definitely. Wait, how old is this?
In stenosis?
Wait, how old is this patient?
70.
70-year-old.
No, this is a renal stenosis. Like that vessel by atherosclerosis is stenosed.
Yes.
Do you get me? It's stenosed. So that drug cannot really do much about it.
Exactly.
Do you get me? So that is actually the mistake we made about the renal perfusion. So that drug is not going to do anything about it. So if it's not doing anything about it, because atherosclerosis is already well established there by
Yes.
So in the other body, lisinopril is going to do what we actually predicted. However, in that renal vessel, it's not going to go and remove the atherosclerosis. Do you get me? So it's a well-established pathology there. So that is the reason why the renal perfusion is still going to be decreased. So I think that's just what we missed there. But someone has already given up. I can't help you there. So intraglomerular pressure, you got it. Why is reducing? It's reducing because the efferent is dilating. If it's dilating, so you know that intraglomerular pressure that is supposed to be building up, blood will now actually be flowing out more, so it will reduce. Do you get me? So that's that. Then the GFR is also going to reduce because the intraglomerular pressure has already dropped. Then you already did all these other ones, so which actually makes sense. So I want you to try this next one. All right, so please, let's pick our answer here. A 72-year-old man is brought to the medical department due to diarrhea and vomiting for the last 24 hours. The patient's daughter states that he has been unable to take in much fluid during this time. He has hypertension treated with hydrochlorothiazide, which he has not taken since the onset of symptoms. And as the blood pressure is 90/60 and pulse is 105, examination shows dry mucous membrane. Analysis reveal concentrated urine with a specific gravity of 1.030. Which of the following changes in renal plasma flow, glomerular filtration rate and filtration fraction are most likely present in this way? So what do you think is going to happen to the renal plasma flow, everyone?
To decrease, markedly reduce,
decrease.
So are we going for A, B, or C?
A, B, C.
So what do you think will happen to the GFR?
It also reduce. So A, B.
Reduce.
Did anyone say increase?
No.
No, reduce.
No.
Reduce. Okay. So our answer is between A and B, Abby. So what do you think will happen to the filtration fraction?
It will increase.
So our answer is A, right?
Increase.
Yes.
Yeah.
Sorry, I'm coming. All right, I want you to solve this one. A longitudinal study is conducted to assess changes in renal function over time in patients with recently diagnosed type 2 DM. An initial set of laboratory tests is obtained and newly enrolled patient to establish baseline renal function. The following measurements are now taken: creatinine in the urine in the serum, glucose in the urine in the serum, potassium in the urine in the serum, uric acid in the urine in the serum, para-aminobutyric acid in the urine in the serum. Which of the following is the best estimate of the filtration fraction in this patient, assuming the urine flow is 1.0? So, what is the formula for the filtration fraction again?
Renal GFR over renal plasma.
GFR over renal plasma.
All right. So now, which of these parameters do you need? Do we want to use to calculate your GFR?
Creatinine.
The creatinine.
Right. So everybody, I want you to calculate. Everybody, calculate your creatinine for me. So what is your GFR, everyone?
100.
Did anyone get on any other person that got 100?
Yes, 100.
Did you all get 100?
No.
Okay. Who doesn't get 100? How did you do your own that you didn't get 100? So this is what you will do. So if you just remember the formula you were writing that time, if you can remember, quickly derive it by yourself. But the net result of it is concentration multiplied by volume over time for the plasma equal to concentration multiplied by volume over time for the urine. I already know concentration in the plasma is 1.1. Volume over time with respect to plasma is what? For the creatinine is the clearance, which is the same thing as what? GFR. Equal to concentration in the urine is 110. Multiplied by volume over time in the urine is the same thing as urine what? Flow rate 1.0. So GFR is equal to what? Do you all get it now?
No.
All right. So when we leave
What is the 1.0 given in the question?
how did this is 1.0 now? The urine flow rate.
Given at the
Urine flow rate. I
Okay,
told you
yeah.
right from the beginning that this V over T is the urine flow rate. V over T here for the plasma is the what? Clearance. Do you remember? All right. So now that you've gotten your GFR, I want everybody to calculate your. If you do your calculation here, you will get 100. So that is how they all got 100. So I want you to do your calculation and calculate your renal plasma flow for me, everybody.
It's 20%.
I'm coming. Okay, what did you get?
20%.
The renal plasma flow.
No. 500.
I'm not calculating differently. Okay. I was calculating differently. It's 500, yeah.
Okay.
I was going to
Now,
the
who got any other person that got 500? So this is what you are going to do. What is the concentration of the para-aminobutyric acid in the plasma? Let us do it together.
100. Oh, in the plasma, 0.
Is 0.2 multiplied by
0.2.
clearance in the plasma is what? Renal plasma flow. True or false? True.
Yeah.
So concentration of the para-aminobutyric acid in the urine is what?
100.
100.
What's our urine flow rate?
100.
1.
1.
1. All right. So renal plasma flow is now equal to. Just get your renal plasma flow from here, Sha. Renal plasma
500.
flow is equal to what? 100
500.
divided by 0.2. So you get 500.
Mm.
So that's how they got 500. So now that we've gotten our renal plasma flow, what is the FF, filtration fraction?
0.2. That's 100.
Divided by
That's
500.
500.
So what is the answer?
0.2.
0.2.
Which is 20%.
That is how they got 20%. See,
So-
let me, if we don't all be, if we are not doing all these calculations, I cannot help you. You just need to start doing them as we are. That's why I say I will allow you to solve all of them. It's not that maybe we don't have anything else to do, because I know how confusing they may be. You just need to be the same formula you've written. This same formula is what you'll be applying throughout. See, it doesn't change. The same way we derived it, the same way you will be applying it. And that's why I told you to try to derive it by yourself, so that in case you can't remember it, you can just derive it. And I specifically told you that volume over time here with respect to the plasma is the same thing as clearance. volume over time with respect to the urine is the same thing as urine flow rate. Nothing has changed. And you can also look at their unit, mil per minute, mil per minute. This one also will be. Okay. So the answer is B. I want you to pick your answer here. A researcher is studying the effect of various manipulations on kidney blood flow and GFR. Which of the following is most likely to both decrease renal plasma flow and increase the filtration fraction? Which one do you think will reduce the renal plasma flow and increase the filtration fraction? Anybody?
Constriction of
constriction of the efferent.
Constriction of the efferent. Why do you think constriction of the afferent is wrong?
No,
there
will be no change in
the filtration fraction will not increase.
Will not increase.
It will increase, right?
It is going to increase renal blood flow.
Okay. So because it's going to reduce the
renal
plasma flow, it's also going to reduce what? The GFR.
Filtration fraction.
Filtration fraction and GFR and the renal plasma flow. Okay, the filtration fraction is going to be constant. Okay, so that's fine. All right. So which answer are you going for? C, right?
Okay. Yes, C.
C.
Good. This one we've already shown you. All right. A 64-year-old man comes to the office after learning at the dentist's office that he has elevated blood pressure. The patient is a combat veteran and has always been fit as a bull. He has undergone various minor surgical procedures for wartime injury. He reports many years of tobacco and alcohol use, but currently uses neither. On careful questioning, he described chest pain on his action. Blood pressure is 155/90, pulse is 76. Physical examination is significant for decreased pulse amplitude over the right femoral artery and a systolic bruise over the left carotid artery. Resting ECG is unremarkable and serum creatinine is 1.1. Urinalysis is negative for protein. Treatment for hypertension is initiated with Ramipre. On a follow-up visit 3 weeks later, blood pressure is 142/85. But serum creatinine has increased to 2. Okay, serum creatinine has increased to 2 with that drug. So ACE high is increasing the serum creatinine, right? Is that true? Is that your what you can decode from it so far now? Do you get it?
Yes.
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 This laboratory finding is best explained by an effect of the drug on which of the following structure. So let us. Where do you think the lisinopril is going to have its effect more?
The efferent.
Efferent. Yes, now efferent.
E.
Okay.
B.
B. Yes, B.
That's B.
Now, who wants to tell me why the creatinine is increasing? Anyone that gets it, what should we give the person?
70 pounds.
Trip to Hawaii.
Kuku say, give me back my money. Kuku collect it back. Upon just one question, you already collect. Why, when you now answer 10 questions, what will you collect? You will collect the whole of concepts. So
it's possible that the GFR has reduced.
Okay, now who want to try? Let's someone try.
Probably the GFR has reduced.
Not the person that will start with probably Dr. Ivioma. Who wants to try?
The GFR has reduced too.
There is no catch there. You should know me by now. There is no catch. I can't lay a trap for you.
Can we see the question again?
There is no question. How is creatinine? How is Ramipre causing increase in creatinine?
It's increase.
Because hyperfiltration.
Wait, who want to try? I will help you. When God is telling you that, do you want to go? Just know you want to go with you.
Yeah, I think Ramipre is.
Do you want to try?
That's what I'm doing now.
You are just trying. You didn't commit yourself to it. You can stop halfway now.
That's what I think.
Dr. Assunta, do you want to try?
That's what I'm doing. That's what I'm saying.
Okay,
yes.
Dr. Assunta, start.
I want to try.
Ramipril, it's reducing constricting the efferent
You wanted to say it's going to dilate.
Dilating the efferent arterioles.
Very good. Very good.
So thereby, I think it's reducing the intraglomerular pressure.
That's awesome.
Then the GFR will also be reduced.
That is superb.
So Dr. Fesco.
So now I know that is where you are likely going to get stuck. I will now come in to help you there. Now, when that GFR is now reduced, what do you think will happen to most of the reabsorption?
There'll be excessive reabsorption because
reabsorption.
Plenty
but as
reabsorption.
there is now secretion of creatinine.
Which secretion again are you mentioning? We just which secretion of what?
Of creatinine.
Which from where again are you secreting it? It's just at the level of reabsorption you should stop, Dr. Assunta. Now,
no, I'm not the one talking. No.
Who talk? Who added reabsorption? Who added secretion to it? Someone that didn't start from the beginning is now adding. All right. So never forget that concept. Anytime I told you that, look at it. Look at the GFR, like water flowing before you. You are sitting where you are sitting. The water is now flowing across you like this, from your left to the right. They now put all manner of balls there. Those balls, they are creatinine, they are glucose, they are all manner of substances. You are the tubular cell. They now say you should pick them up. If the rate at which that thing is flowing is high, you can only pick few. Majority of them will be lost in the urine. If the rate now drop, GFR drops, you can pick every damn molecule that is there. So reabsorption is going to be high. Yeah. And that is the reason why that patient, because of that reduction in the GFR that occur, the reabsorption, like all those picking of all those creatinine, is going to the tubular cell will take their time and pick almost everything up. And that is why the creatinine level rises. Why do you think a patient with chronic kidney disease, creatinine level will continue to rise? The same principle. GFR has fallen. You remember the grading. That GFR that has fallen, like it has fallen completely. Initially, the GFR was running. Now,
just said whenever it's less than 50%.
Do you get me? Now jogging. After a while, they grade it again. They say it's now crawling. After a while, it's now like moving somehow. So that's why the creatinine you will be seeing is going to be very high, because the tubular cells will now pick a lot of creatinine. They will reabsorb a lot back into the blood. So you can look at it like that. That's number one. The majority of them will not be filtered at the glomerular level. That's number two. So that's that about that. I want you to answer this question for me. A 44-year-old man comes to the office for a routine checkup. Past medical history is significant for hypercholesterolemia, which he has controlled through diet. His father died of a myocardial infarction at age 56, and his mother, who is still living, has a history of stroke. On physical examination, the patient's blood pressure is 160/100, and the heart rate is 70. He is started on enalapril. During the first 7 days of therapy, the patient glomerular filtration rate adjusts as given in the graph. Which of the following structure was most likely affected by a downstream effect of enalapril and is therefore responsible for this patient's renal response? So I don't know the graph that is there, but which structure do you think is likely affected by the enalapril? Let us assume that. I don't know the graph they are giving, but let's see if I told that's what they are testing. That's what they are testing. All right. Let me show you the graph. But let's continue. You can see it in your stuff. All right. 60-year-old woman is being evaluated for abnormal renal function. She is found to have a serum creatinine of 2.2 on routine laboratory monitoring. Her creatinine level a year ago was 1.2. The patient has a history of non-ischemic cardiomyopathy and systolic heart failure and has been on a stable medical regimen. She has no dyspnea, fever, rash, or lower extremity swelling, but has been taking ibuprofen for 2 weeks due to left knee osteoarthritis. Urinalysis reveal the following: protein is none, WBC is none, red blood cell is none, sediment is none. Ibuprofen is discontinued and her kidney function returned to normal in a week. Which of the following best explain the patient transient deterioration in renal function? Who knows that?
I think it's A.
Afferent.
Impaired.
Pick one.
Afferent.
Think. Pick one.
A. A is the answer.
So impaired afferent arteriolar vasodilation. Do we all agree with that?
Yes.
Because
Yes, sir.
prostaglandin should dilate the afferent. Now, when we reduce the production of prostaglandin, there will now be what? Constriction. Exactly. So the answer should be here until proven otherwise. So a 45-year-old man comes to the office for an annual medical visit. The patient has had pre-diabetes for the last 2 years. He feels well and takes no medication but has gained weight since his last visit a year ago. The patient has a strong family history of type 2 DL. Blood pressure is 124/70. BMI is 32. Laboratory results show a fasting blood sugar of 156. Serum creatinine of 0.7. Serum creatinine of 0.7. Who want to tell me why the serum creatinine in this patient at this level is this high? I mean, it's low. Who want to tell me? Because the first person that answered the first one had no gift. So you thought that there is no reason to say anything.
Is it the
He's
BMI?
pre-diabetic and there's
No
no.
one should talk. No one should give chorus answer. Who want to tell me why in this patient with diabetics, like this level, look at the fasting blood sugar is this 157. Look at the serum creatinine is now 0.7. Who want to tell me why? Dr. Obi?
Because
Thank you. Yes.
the patient is going through the first phase of there is hyperfiltration.
Hyperfiltration one.
So
hyperfiltration, yes. Dr. Obi, you just give hyperfiltration and you disappear. With that hyperfiltration, GFR, don't forget, is very high. So there is no time to even reabsorb creatinine. Majority of them are lost in the urine. So when you check the patient blood, the creatinine will be low. All right. Thank you so much, Dr. B, for giving us half-baked answer. All right. So they now ask you, hemoglobin A1C is 7.4. Urine assay shows no detectable albuminuria. What do you think normally repel albumin at the kidney level? Anyone? At the glomerular, this thing. What is that thing?
Negatively charged.
Negatively charged.
Charge basically.
Podocyte.
Exactly.
Yes.
No, not podocyte, just those basement membrane basically, because they are made of protein that are conferring negative charge. So which of the following renal changes is most likely present in this patient at this time? This time presently. So what do you think is going on?
Increased GFR.
Increased GFR. Someone is
Filtration
going for
rate.
increased GFR. That is what I would have gone for anyway. So why are you going for increased GFR here?
Because of hyperfiltration.
I think that's what she answered. The hyperfiltration, then the creatinine is being sharply
Lost in
low.
urine.
Okay. Well, you are going for increased GFR because of that thing I explained to you. So you need to have the understanding that as those glucose are filtered, so a lot of them, do you get me? initially a lot of sodium will be reabsorbed at the proximal convoluted tubule. Sodium that will get to distal will now be low, and macula densa will be sensed. This one will now stimulate the juxtaglomerular cell release renin. Renin will eventually cause what? Increase in the production of ACE, angiotensin 2 at the later on. Angiotensin 2 will cause what? Vasoconstriction of the efferent. So with that one, there will be increase in intraglomerular pressure. So you expect the intraglomerular pressure to actually increase. They put reduce here. So the answer is what? Increased glomerular filtration rate from that increase in intraglomerular pressure. Apart from increase in intraglomerular pressure, all those glucose also entering. Do you get me? There is a way. They also have a way of influencing filtration rate. The last question for you. A 70-year-old woman is brought to the emergency department 1 hour after being found unconscious in an apartment by her neighbor. No medical history is currently available. His temperature is fine, pulse is high, respiration 18, and blood pressure 70-50. 70-50. Laboratory studies show a glomerular filtration rate of 70. Normal should be greater than 90, and an increased filtration fraction. Which of the following is the most likely cause of this patient finding? Of what do you think is causing increased filtration fraction?
Increase
renal blood flow.
So reduce renal. So what do you think? Which of the following? Which of them do you think is likely responsible for it?
multiple
Filtration fraction too. Don't forget that GFR has already reduced, right?
Yes.
Yes. So for the filtration fraction to now increase, then it shows that the renal plasma flow must have what? Must have been reduced far more than what?
Significantly.
Exactly. So what is that thing that can make the renal plasma flow to reduce far more significantly than the
Dehydration.
dehydration? So what is your answer now? Shaking. And that is how you will be looking. So all you need is to go back and rehearse on all these guys, like solve them again, and you will be fine. But if you think you are fine already, don't bother to solve them. All right. So let me allow us to go for 15 minutes break. Then we come back and do something. Then, I hope we don't need break, ne?
We need break.
Dr. Juliet is already saying it's well. Dr. Juliet, you already